We'll straight away go to the next session, which is the induction of the new batch. And to begin with, on behalf of my co-moderator, Dr. Anaga Harur, I would like to welcome all of you to the 23-24 batch. And I would like to request you to begin with giving a very brief introduction of yourself within 1 minute. So I'll call out the name and I'll call out from below. Yes. Yeah. So I'll call out from below and then you can introduce yourself and then we'll start the debate which is there. I would also like to... आपका कहाँ पे है? हाँ तो करके आ जाइए. Also, I'd like to welcome the expert panel, Dr. Jatinder Bali, sir. Welcome to this induction of 2023-24 LDP batch.
Am I supposed to take a bow?
Okay, so now I'd like to request you, Dr. Vinita Gupta, to please introduce yourself.
I'm Dr. Vinita Gupta. I'm working as...
Mic on karna.
Yeah, I'm Dr. Vinita Gupta. I'm working as a faculty at All India Institute of Medical Sciences, Rishikesh. I'm specialized, I'm doing specialized work in pediatric ophthalmology and cerebrospinalogy as well as glaucoma. These are two my fields of specialization. And obviously being in an academic institute, I've upgraded myself also. Like I have all those fellowships and from UK. Of both the Royal Colleges of UK, the Glasgow College, Royal College of Physicians Surgeons Glasgow, as well as the Royal College of Ophthalmologists. And I have been inculcating the same systems of examiner and the teaching which goes on out there in UK into my Indian system of teaching out in AIMS Rishikesh since I've become a teacher there. And anyway, I have a session to start. Anyway, I have a session to start in the next. My introduction course I'll be running anyway. So thank you. Thanks. That was all about.
Thank you so much. Dr. Vijay Sharma is here.
Dr. Vijay, do we have Dr. Vijay here?
Dr. Vijay Sharma.
So Dr. Vijay is not with us.
Dr. Vandana Prasad.
Dr. Vandana Prasad, please.
Dr. Tanvi Qureshi.
Dr. Tanvi Qureshi. Sir, would we have the next one also? Tanvi here.
Talveer Sidhu.
Address the audience. Face the audience.
Very brief
Hello.
introduction. Your name, where you are, your accreditation.
Hi everyone, I'm Dr. Tanvi. I'm basically from Gujarat. I've recently shifted to Mangalore. I have done my PG from MGM Aurangabad and my specialization in medical vitreoretina and ROP from HV Desai Pune. I've recently gotten into teaching and now I have to speak on the mic a lot, which I'm scared to do, hence LDP. Looking forward.
Very good. Thank you very much.
learn.
Welcome to the LDP program. Now I'd like to invite Dr. Talveer Sindhu. He is not here. Dr. Swapnil Gavit.
Dr. Swapnil.
Dr. Soumya. Dr. Soumya HV.
And who's the next one?
Dr. Sayatan Ghosh.
Good afternoon.
Dr. Ghosh.
Yeah, good afternoon, everyone. I'm Dr. Soumya. I'm from Mysore, Karnataka. I'm an associate professor at JSS Medical College, and my specialization is medical retina and ROP. And I'm also done my advanced course in medical education and member of medical education unit. And I look forward and I really enjoy the sessions of LDP and look forward to a great program. Thank you so much.
Thank you. I'd also like to welcome the expert panel, Dr. Rajendra Prasad, sir. Can you please come in front, sir?
Who's the next one?
Sayatan Ghosh is not here. Okay, now Sarvanan Jyoti, Sai Kiranmai P.
Dr. Sarvanan is there.
Dr. Sarvanan is there.
I am Dr. Sarvanan Jyoti, senior faculty from Coimbatore Medical College from Coimbatore, Tamil Nadu. And my specialization is in vitreoretina, and I have done a FICO and trained in Italy. And I have been there in the teaching faculty.
Hold the mic closer.
I am in the teaching line for more than 17 years, and I'm very interested in academic as well as to be a part of this LD program to improve my leadership quality and my administrative skills. Thank you very much.
Dr. Sai Kiranmai.
Good afternoon, everybody. I'm Dr. Sai Kiranmai. I'm a vitreoretinal surgeon from Hyderabad, from Pushpagiri Eye Institute. So it's very interesting development program, and it is very required because it's not enough to be a good clinician, because we have so many people around us to manage, right from the patients and all the OT staff and everybody. And in fact, I started learning little leadership from my ROP work, which I do, because it is always a teamwork and requires a lot of approach and lot of other departments being involved in it. So it is very interesting to know about that. And
Thank
being
you.
a woman also, we need to be a leader in the house.
Thank you so much. Welcome to LDP. Dr. Ritesh Verma. Dr. Ritesh Verma is not here. Dr. Rakhi D'Cruz. Dr. Rajesh Sahai. Rakhi D'Cruz.
Hi everyone, I'm Dr. Aki D'Cruz. I'm currently working as a consultant at Ahalya Institute, Kerala itself, and my areas of specialization are FACO as well as medical retina. Thank you.
Thank you very much. Dr. Rajesh Sahai. Dr. Raghav Malik. Dr. Radhika Paranjpe.
Good afternoon, everyone. I'm Dr. Radhika Paranspe from Pune. I'm an associate professor at D.Y. Patel Medical College, Pimpri, Pune, and also a member of IQSC of D.Y. Patel University and Medical Education and Technology. I recently got elected as the president-elect of Pune Ophthalmological Society. And may I add, I was enrolled before I got elected in this program.
We cancel that. Next one, sir. Who's the
Purva
next
Singh Narang.
one? Dr. Purva.
Hi,
Purvasha, sorry. I'm
good
very sorry.
afternoon, everyone. That's Purvasha Narang from AIMS Nagpur. I have joined as faculty there, and as an associate professor, I'm a practicing cornea person, and recently had the good chance of starting an eye bank also over there. So it's just tiny steps towards building up a new set of department. So that's my key takeaway from.
Thank you very
the
much.
leadership.
Welcome to LDP. Dr. Prabhat Singh. And in the meanwhile, Dr. Gayatri Dasari is here. Dr. Gayatri, you are here. Dr. Yeah, Dr. Gayatri. Yeah, please sit down. We just wanted to know whether you are here. Are you ready with your Are you ready with your presentation? Okay, good. So, Dr. Prabjot Singh, Dr. Niranjan Karthik, Dr. Nilesh Kumar.
Good afternoon, everyone. I'm Dr. Nilesh Kumar. I'm medical director. I finished my PG 2 years back, and now I'm medical director at my own setup. And I'm doing. By training, I am a retina person, but by default in Bihar we have to do cataracts, so I am a paper refractive as well. And I am joint secretary of Young Ophthalmic Society of India. And as Anaga ma'am was telling, we should not wait to reach a certain level to start learning how to be a leader. So that's why LDP. Thank you so
Good.
much.
Welcome to LDP. Dr. Nikhil Kanduvar. Dr. Nikhil. Dr. Meghali Bhattacharjee. Dr. Manjushri Bhate.
Hi, I'm a pediatric ophthalmologist. I work with LV Prasad Hyderabad. I'm involved in a fair bit of administration, and I thought this LDP would be really useful. So thank you so much.
Thank you very much. Warm welcome to you. Dr. Jitendra Vidhani.
Good afternoon, everyone. Thank you to the esteemed faculty and the Academic and Research Committee for the opportunity. I am Dr. Jitendra Vidhani from Ahmedabad, Gujarat, a second-generation ophthalmologist. I've recently completed my fellowship and I've joined my father. And on weekdays, I am an ophthalmologist, and on weekends, I'm a musician with my band and my guitar. So thank you very much.
Welcome aboard. Welcome aboard. Dr. Gagan Bhatia. You guys are going.
I'm Dr. Gagan Bhatia. I'm a vitreoretina surgeon who's been practicing in Delhi for the last 15 years now. I am currently associated with Shropeye Centers, and I love what I do and hopefully get into the leadership role as well. Thank you.
Thank you very much. Welcome. Dr. Dipankar Das. Dr. Dinesh Ray.
Hello everyone, I'm Dr. Dinesh Ray. I'm from Raipur, Chhattisgarh. I do private practice. I am Director DJI Hospital and I am also Joint Secretary Raipur Division of Ophthalmic Society. Thank you.
Thank you very much. Dr. Dhrumil Kisaria.
Good afternoon, all. Myself, Dr. Dhrumil Khisaria. I'm basically Gujarati but settled in Kerala since more than a decade. I'm a cataract and VR surgeon, founder and head of New Vision Eye Hospital at Mundakaim in Punjab. And I'm also serving as a secretary of Kottayam Ophthalmic Society, past secretary of Idki Malnad Ophthalmic Club. Would like to join LDP for doing something better for my organization as well as state and national society. Thank you.
Very warm welcome to you to LDP program. Dr. Bharat Mehta. Dr. Aios Singhal.
Hello, I am Dr. Ayush. I am a cataract and refractive surgeon. Right now, I have my own hospital in Hisar, Haryana, and having some hiccups in initial practice. So that's why for LDP.
He's a wonderful person, though. You will have a lot of fun through the next 1 year. Next person is Dr. Ashwini Kalia. Dr. Ashish Bachav. Dr. Anthony Akradas Bhaskaran.
Hello everyone, I'm Dr. Anthony and I'm a pediatric ophthalmologist from Nagarkoil, which is in Kanyakumari district. I'm working with Bejan Singh Eye Hospital. Previously, I was an associate professor with Joseph Eye Hospital in Trichy, and then I had to do some administrative work as well. That is how I got an interest into administration. And I hope I'll be learning a lot in this LDP program along with all of you. Thank you.
Dr. Ankit Agarwal.
Good afternoon, everyone. I'm Dr. Ankit Agarwal. I'm a cornea, phaco, and refractive surgeon. I'm working as a consultant in Eye Clinic, Prayagraj.
Dr. Anshu Deka.
Hello everyone, I'm Dr. Angshuman Deka. I'm basically from Guwahati. I have done my fellowship in oculoplasty from Sri Shankardevan Netralaya, Guwahati. So I'm working as a consultant in a private hospital in Guwahati, which is called a Retina Center. And I have also started my own practice, private practice. So I'm looking for the LDP program to enrich myself and develop myself and help in future through AIOS and the program. Thank you so much.
Welcome, welcome. Dr. Ajit Kumar Poddar.
I am Dr. Ajit Kumar Poddar and I am the medical director and trustee of Akhan Jyoti Eye Hospital. And Akhan Jyoti Hospital works in Bihar and Western Uttar Pradesh. And I have more than 21 years of experience in ophthalmology. And I believe the leadership has nothing to do with the position, it's about the action. So thank you.
Thank you very much. Dr. Neeraj Shah.
Good afternoon, everyone. Thank you, ARC, for making me a part of this LDP. So I am basically from Gujarat, studied in Maharashtra and Tamil Nadu, married to a Odia girl, worked in UP, now settled in Rajasthan.
Wow.
So I am the chief medical officer and I manage cataract, cornea and refractive services at Shankar Eye Hospital, Jaipur. I have been part of Shankara since the last 12 years and I'm a part of their leadership team and the training there. So thank you.
Thank you very much. And to give you a brief description, I am Dr. Satyajit Sinha. I am the Academic and Research Committee member for East. This is my second term. And I really want to let you know that I was from the first batch of LDP way back in 2005, where Dr. Natarajan arranged this in a small room in Bombay. So since then, I have been attached with LDP. And through this 1 year, and for the rest of your life, all this group which is sitting here, you'll become thick of friends meeting in each conferences. And most of all, I want to request you that you will have two programs. One which will be in Bombay or Pune and one in Bangalore, which is done by Pegasus. And that is the program. If you don't have something very urgent that you should not miss it, But this program, these two programs which are there, in which there'll be a lot of outdoor activities, in which there'll be management gurus, educational gurus. If you miss those two programs, it's not worth doing this LDP program also. So you will have that schedule. Please make sure that you do attend those two programs which are there. And then again, we'll see you in Calcutta in 2024 for your completion. So we wish you best of luck. And definitely, if you really want to take out from this, attend these two meetings and you'll really benefit a lot. So a very, very warm welcome to all of you in this program. And once you pass out also, once you become an alumni also, you can keep attending these programs. And there's an alumni reunion also on the Balgati Beach. You can be a part of that. But a very warm welcome to all of you. So now we'll begin with the debate which is there and which is going to be very interesting. Dr. Rolika Bansal is here. Yes. So we'd like to invite, and Dr. Rolika has a lot of sessions all over the place, so she has to go somewhere. So we have just upgraded her. And she just, you won the Rangachari Award yesterday? Yeah, so congratulations. A big congratulations to being the youngest awardee for the Colonel Rangachari Award. And you're not the youngest, but that was what was announced yesterday.
Santosh Chunave sir is.
Okay, okay. Murugan darwaja band kar do na khali. So the debate is between Dr. Rolika Bansal and Dr. Gayatri Dasari. And Dr. Rolika will be speaking on productivity of research days in private practice is underrated, yes. And I would like once the talk is completed, we would like comments from Dr. Jatinder Bali and Dr. Rajendra Prasad.
So may I begin? Okay, so productivity of research days in private practice is underrated. Well, oh yes, that is true. Absolutely true, and I'll take you through how. So there are 5 components which are very important for any private practitioner. Let's take them one by one. First is absolutely money. Is that right? So all the private practitioners, you landed up being a private practitioner probably because there is a lot of money involved, which you don't get in a government practice. So yes, money is important. But is it all about money? Yes, of course. I wouldn't say that anybody would deny that. But at the same time, one thing that people forget very often is research also is equal to money. Because if you are oriented to the latest research protocols and the latest modules that are going on, then you will have newer advances and better drugs, which probably cost more. So it is all about money. You have it covered. So the next point is knowledge. It is quite important to stay updated. It's important for you to be treating your patients with the latest regimens or latest protocols that are available. Please publish. You get, as private practitioners, you get very interesting cases which you wouldn't probably get in a government hospital. So in a government practice, you land up getting multiple patients, of course, a variety. But in private practice, you will find very interesting cases. In fact, if you go through the latest IGO case report, 40% are from private practices. So that is quite significant. So feel good and do good. It is important for you to know what is going on. My parents are also private practitioners, but probably they do not like to stay so updated. But it feels good when they realize, when they read something new coming up, they're like, okay, fine, we can do this. It's not about CMEs only. It's all about reading, and you should have a specific research day, one day a week. So present and share your work. I can see so many private practitioners in all the conferences and all the halls over here presenting their work, and I think they do that because they have their own research days. Yes? So what about the next one? Take a break. I really think, yes, it is a break. To have one day where you have no patient hustle, when you can actually sit down nicely and think about what you have gone through and what more you can do for your patients. All of us geeks have those days as a mental break. So believe it or not, it is actually a break to have your research days. Next option would be you versus Dr. Google. So your patients are absolutely educated and non-educated at the same time. The patients are more updated. They read and they come. They have Googled every single thing about their disease that they can think of under the sun. And they really need to show off about your doctor. So when they go to the, you get, as private practitioners, you get the cream of the society mostly, right? So when you sit over there and give them recent advances which they have already read on Google, they like to show off about your doctor. Right? They go and they go like, my doctor already knows everything. And it is important to kind of come back and help them understand their mistakes. And the next point is suit up, because it helps you in teaching and take care of ethical approach as well. Save money from lawsuits, please. It helps you if you have your research days protocols ready. So research days are quite important. And just to throw in an example for a mic drop moment, so this was a study which was done called a cosmic study. 40% people who participated in this study were private practitioners. And take a guess, who do you think, where do you think was this study carried out, and how many days do you think it took for this study to carry out? And as I have said earlier also, when someone asks me guess what, I never say, I just say what, because this is how I'll take you briefly. The idea's conception was on 24th May. That is the day one. The survey was out within 2 days. The madness and chaos and every single thing in between was within 10 days. 5th June was when the manuscript was ready and printed and sent for the review. And again, the reviewers came back with questions which were not easy. And then on 8th June is when it actually got published. So this study had a very good citation, multiple posts. It helped a lot of practitioners. And where do you think the study was carried out? It was carried out in a private practice on a single floor, and it has done pretty well because we have our own research days. So yes, for the research days.
So before the comments, we'll like to have the opponent speak. Dr. Gayatri Dasari, please. And in the meanwhile, we have candidates from 2022-23 here. Okay, so we have your completion certificates, which we'll be giving just now.
A very good afternoon to everyone. So before I tell why the productivity of research days in clinical private practice is not underrated, a brief importance of the private practice, conducting research in the private practice. Definitely the patient pool and the treatment needs which attend the private practice are different from the patients who attend the public healthcare delivery systems, and the infrastructure and the resources available also are very much different. And conducting a clinical trials in the private practice will increase the community awareness of one's own practice, and definitely interesting cases deserve to be written up and presented in CMEs and conferences. And research grants and funds are becoming scarce, so there is an increased need in private practices to take up more research. And definitely it is intellectually stimulating and rewarding by identifying new treatment strategies, evaluating the effectiveness of the existing treatment, and enhance the healthcare experience to the patient. So usually the measures of productivity in private practice commonly is number of patients seen, number of procedures performed, revenue generated per physician, patient satisfaction rates. But you even have to show the number of dedicated research days which you have incorporated in the private practice. And how do you set aside a dedicated research days in a week, which consists of reviewing the medical literature, analyzing the data of your patient outcome, conducting the clinical trials, and most important, collaborating with other healthcare professionals, your competitors also. So what are the challenges you come across in your private practice? Definitely time constraints, smaller patient pool, time consuming administrative duties, management of the personnel, and no access to the mentorship. But it can be overcome by seeking the ethics committee approval, CTR, that is Clinical Trials Registry of India, SOPs, establishing the proper infrastructure, recruiting the trained team, and personal conversations with the patients to improve the enrollment. And most important, partnering with the like-minded colleagues for another research site, which will have a financial advantage. So these are the more examples of the private practices in ophthalmology who have contributed significantly to the advancement of the medical care and improvement. That is innovations in femtosecond laser-assisted cataract surgery, MICGS, and innovations and development of toric multifocal lenses, and innovations of new diagnostic facilities, and development of low-cost intraocular lenses, and teleophthalmology. So the conclusion is research is definitely a professional responsibility which contributes to the advancement of medicine and improvement of patient care. Significant benefits for both clinician and patients are there. That is improved patient outcomes, increased revenue, and more competitive edge in the industry. Research leads to the development of new approaches and identify gaps in the current literature, and private practices that prioritize the research can attract top talent and foster culture of continuous learning and improvement. Thank you, LDP.
Thank you. Comments by Dr. Jatinder Bali, sir.
I think both of them have already supported, so it's hardly a debate. And I also feel, all said and done, I think it is the correct way forward, because what happens is that in institutions, it's a captive research, because a resident is doing something that has already been tutored by somebody who's decided this is what he wants done. And then, I have a lot of DNB students who come. I'm in a multi-speciality hospital. So I have had this occasion where a student comes and tells me that, you do this, and then you do rationalization of results. So you can understand what he's trying to imply. And he's convinced that this is a valid research step. And now, so far as practitioners are concerned, you see, there is that intangible knowledge which is being wasted by it not being published. So what is more important to understand is, if you do not publish, if you do not set aside time for thinking about it, it's an investment. One is the patient that you see, that is your revenue. You see, it is like a blank check. But whatever research or whatever things that you're doing for research is your investment. It may come through, it may not come through. I will give you the example of Dr. Rajendra Prasad. He is in a private practice, but he's won awards at the American Academy and awards for innovation and being in a practice. So I think the biggest example of why you should have your days is like you should set aside research days. That's up to you. How many hours? It need not be a full day, but you do need to set aside some time.
A quick comment by Dr. Rajendra Prasad.
I think both of them very well supported the research in private practice. So private practice, see, in a government institution, it's very easy to do. You have a support, you have a system over there. But in private practice, definitely you have to create your own support and your own system. And it takes a lot of investment. I came out from RP Center in 1984 and straight went into private practice. Started with a very small clinic. Rather, I was first worked in a optical shop. But my mind from that day itself, because when I came out from the RP Center, research was the first thing which was in my mind. So I invested some money to create my own lab. I have a lab, a full lab with support, a lot of machines for the lab to develop the instruments, to know the physics of the instrument and all these things. We have a complete support for that. So we have a complete lab, and it was quite difficult to create that lab. But yes, if you have a goal in your mind to what you want to do, you can do everything. Okay. So there is no limitation, no restriction in doing research in private practice. We should all have this in mind, that because the research is the most important thing. So you do the clinical work, you see 100 patients, 200 patients, that won't satisfy you at all. See, after all, it's the work which you are giving to the people, to the community and to your society, the work you are doing at your own level, which helps to the students.
Thank you very much. So the take-home message for all the leaders of tomorrow is, do invest time in research and do publish. Both of you are winners, Dr. Gayatri, Dr. Rolika. Thank you very much for your wonderful presentation.
And I should say that my worthy opponent actually became my worthy partner in crime. Thank you so much.
Thank you very much.
And one take-home message, I think, is try to create networks. Try to create networks. because institutions and outside institutions, it's the networks. The moment you collaborate, there was a Cosmic was a collaborative study. So it takes years to create your own facilities, but if you reach out, people already have the facilities, you will get those facilities. Over to you, Dr. Sinha.
Thank you very much. We would like to invite the next speaker, and if the first speaker doesn't mind, Dr. Akshay Goyal is there. Dr. Akshay Goyal will be speaking on free cross consultation is neither appreciated by patient or management. Yes. And then Dr. Ambika Shetty is here. Okay, so we'll come to you.
Hello everyone, I am Dr. Akshay Goyal and my topic is free cross consultation is neither appreciated by patient nor management. Yes. So when
Please
I say
stick
free,
to 3 minutes only. 3 minutes.
so when I say free, what comes to your mind? Everyone loves freebie. Muft bijli, muft pani, free pizza, and in our case, free consultation. Why do we do it? Because we may know the patient. We may want to help our peers, another doctor, and sometimes we may even feel pity for the patient. That's why we go ahead and do a free cross consultation. But we need to stop and think again. From the patient's point of view, what happens is he starts getting doubts in my mind. Is it really necessary? Was there a mistake in my previous treatment? Was the free consultation complete? Did the doctor give me enough time? Are they trying to cover something up by doing all these another extra free consultations? And what about my privacy? Are they circulating my medical records to other people with no use? And that leads to loss of value for the free cross consultation that they received, which we have all experienced at some time or the other. A free consultation was never valued by the patient. And it also leads to a loss of credibility of the first doctor who referred the patient for the free consultation. And for the management, it is loss with 3 exclamation marks because of 3 things. Revenue, of course, self-explanatory. Resources, because the doctor's time, staff time, every other equipment, everything there may be an issue. And credibility, because the patient may think that this hospital, they do a lot of these consultations here and there, free consultations, because their doctors are not sure about what they are doing. And from the doctor's point of view, it will lead to unhappy patients because they are not satisfied what is going on. Time management becomes an issue because there have been times where I have had to travel to other hospitals to actually do a free cross consultation. And it leads to loss of self-worth. The patient does not value the free consultation that was provided to them. And once you provide a free cross consultation, they will expect it again. So to summarize, avoid free cross consultations. Thank you.
Okay, so to oppose that, Dr. Rajesh Joshi will be speaking on no about free consultation.
Thank you, Akshay, for that wonderful talk. In fact, you have created background for saying me no. Yeah.
3 minutes.
Yeah. Thanks, ARC, for this opportunity. Can I have my slides, please? I can't see.
Ambika, your opponent is there, Anshu? Okay. Is anybody from 2122 here? Nobody. Huh?
So
2122. 21.
Yeah, free cross consultation is neither appreciated by patients nor management. No. What is the meaning of free? Free means no charges. Can send patient freely across one consultant to another for proper care. The quote conveys everything. It is health that is the real wealth and not the piece of gold and silver. So that conveys everything. What is cross consultation? In the medical profession, it refers to a process wherein a physician or healthcare provider seek the opinion of another physician or specialist in a different field regarding diagnosis or treatment of the patient. Why cross consultation is important? For specialized opinion or additional expertise which is required, because you are not supposed to know each and everything, for better optimal care. Why cross consultation is important? Cost saving. While cross consultation may appear costly at first, what Akshay has told, but it can save money in the long run by preventing unnecessary tests, procedures, and hospitalization. This approach can be appreciated by management as it can help reduce the healthcare costs. Why cross consultation is important? It improves your reputation. Offering cross consultation as a service can enhance a healthcare provider's reputation as a patient centered and comprehensive care provider. Patients and their families are likely to appreciate the extra efforts you have made by providing care by the best of the hands. Competitive edge. By offering cross consultation, healthcare providers can gain a competitive edge by differentiating themselves from other providers in the market. This is especially important in the current healthcare environment where patients are increasingly seeking high quality and competitive care. Why we have so many subspecialties? They are for better care. You are not supposed to know each and everything. To create, it creates jack of all and master of none. So if you are a solo practitioner, you can either practice retina, oculoplasty, or cataract, whatever. It avoids medical litigation. As you have taken specialized opinion, share of burden of stress and tension. So true. The strength of the team is each individual member. The strength of each member is the team. So in conclusion, cross consultation is an appreciated service by patients and management alike, as it can lead to better patients outcome, improved physician collaboration, cost saving, and an enhanced reputation. Collaboration allows us to know more than we are capable of knowing by ourselves. So that conveys everything. Thank you.
Thank you. Quick comment by Dr. Jatinder Balis.
I think there's a dichotomy here because what we are looking at is free cross consultations. So, cross consultations, yes, acceptable. The topic that, okay, do we put it to, we vote? We don't.
No, we just need your 1 minute comment and sir's 1 minute comment.
Okay, so I think I would not go in with the with the free consultations because the topic says free cross consultations. Whether they are good for you or whether they are bad for you, as a marketing strategy, maybe people have used it. But I'm working with the government sector, so I'm probably not in the correct position to be talking about it. But I frankly feel that when you go to a lawyer, you don't get you go to a second lawyer, you pay him for a cross consult. So I think that should be
Dr. Rajendra Prasad.
What do you say, sir?
In short, no free consultation.
Dr. Rajshekhar, sir.
See, this word free and getting appreciation from the patient should go out of our minds. The only thing that you get paid for in this profession is for your knowledge, skills, and expertise. If you are giving it for free, you call it as subsidized or your charity or something like that. But don't just offer it for free. Like the first speaker said, over a period of time, it reduces your credibility. And people are ready to pay for your quality, for your services. So in your case, you meant that one person may not know everything and hence he takes the help of another colleague. That means the first colleague, whatever charges he has taken, he has to give it to the second colleague. It's not going to be free. Why should the second colleague give his services free? That's the only bread and butter. You don't have anything else. The only reason why you earn anything is for your knowledge and skills. If you are doing it for charity, you do it. You are doing it for philanthropy, you do it. But you are doing it as a profession, don't call it as free. Like, that doesn't exist. Free doesn't exist.
Yeah, that's why I told you that free means that sending a patient across freely for consultation, and free means that.
Then initially you charge more. Then initially you charge for equivalent of 3 consultants and all of you share.
No, he's played on that word, free. Freely.
No. Then you be clear. Then.
Unfortunately, that was not what.
So then what you mean is.
So that is a confusion.
So when you have seen one patient, you can refer to another colleague and he can charge for his fees.
Yeah,
but referring should be free, freely referred. Yeah, that is there. That is there. What you can't treat, don't treat. But don't call it as free in monetary terms. And all the youngsters, no free lunches, because that's where we have hit ourselves.
This was a difficult topic to defend.
Okay, for paucity of time, we'll move on. For the 21-22 batch to give out the certificates, we are just waiting for Chitra ma'am to come. It'll just be another 5 minutes and then we'll give you the certificates. You have already completed 2 courses. Because of COVID, you couldn't get it. So we'll just wait for 5 minutes for Dr. Chitra Ramurthy and then we'll do that. In the meanwhile, we would like to go on with the next debate in which we would like to invite Dr. Ambika Shetty, who will be speaking on investing in the latest investigative and treatment modalities is the only way far faster growth in the current era. Yes.
Thank you, sir. Warm good afternoon to all of you. First of all, I wish to thank ARC, Dr. Anaga ma'am, Dr. Satyajit sir, and Dr. Chitra ma'am for giving me this opportunity. So my topic for today is investing in the latest investigative and treatment modality is the only way for faster growth in the current era. And yes, I'm going to speak for the topic. So many of you may be familiar with this institute. It is the Bascom Palmer Eye Institute in Miami, United States. It has been ranked as the #1 eye hospital in the United States 21 times by the US News. So the Bascom Palmer Institute story, it was founded in 1962. The founder, director, chief was Dr. Edward Norton. And there was a team of 5 very famous doctors. They were called Famous 5. And the legacy is compassionate patient care and investing in world-class scientific discovery and clinical innovation. So they are credited with many firsts: fundus fluorescein angiography, vitrectomy, limbal stem transplant, and many such firsts, a lot of credits which we are all familiar. So coming to the history of ophthalmology, in the last 30 years, we've seen a paradigm shift in the diagnosis and treatment of ocular diseases. So even in the Indian scenario, in the National Program in Control of Blindness, we've seen that there is emphasis in investing in the state-of-art technology, be it in government or private care. We've been able to reduce the prevalence of blindness by investing in technology. That is very evident to all of us right now. So in my own practice, that is, which started off as a solo practice and now it has grown to a multi-doctor practice, I saw that we had an incremental growth in our OP statistics. But there were years when we have invested in certain technology, like when the retina started functioning, we saw that there was an exponential growth in the OPD and even in the cataract surgical load. So we were able to increase our capacity and the number of staff by investing in technology. Also, when we look at the projected revenue growth in the eye healthcare sector, definitely there is going to be a lot of growth. Around 5.6% is the projected growth rate. So the secret of change is to focus all your energy on not on fighting the old and on building the new. So we are all familiar with these brands, that is Kodak, Nokia, and BlackBerry. They did not invest in the or adapt to the change in technology. So I appeal to each one of you, don't become outdated like them. You are a smart ophthalmologist. You have to be updated with the latest technology and be bold to invest in it. Thank you.
Thank you, Ambika. Can we call Dr. Anshu Khare? So Dr. Chitra wants to give the certificate for all the batches once all the debates are over. And that's the time she'll be joining us, maybe earlier. So I just wanted to inform you about that.
Thank you, ARC, Dr. Chitra ma'am, Dr. Anaga ma'am, and Dr. Satyajit sir. My friend has very, very beautifully, told the upgradation of the technology, but I stand no, because all the private practitioners, like the NGOs, the corporates, and the institute today, they started the practice as a solo private practitioners. So they have grown step by step, not in one day, investing too much initially. So success is neither magical nor mysterious. It's the natural consequence of consistently applying the basic fundamentals. Does it make sense? When you start your practice, huge investments, see the cost and the benefit. And finally, with the loans overloaded, you might be drowned in the debt. How will you recover the cost? Financial burden is definitely borne by the patient. You ask them more, you order a battery of tests, huge hospital bills, and where are your ethics? Your integrity, your values is again questionable. And sometimes exhaustive tests can lose your patience. So over promising, because you are investing so much, so over promising, under delivered will lose the trust, will loss of confidence, and finally the reputation. So you have more dissatisfied patients. Technology definitely comes with a lot of limitations. High cost of maintenance, regular upgradation, regular innovations, regular technology coming every day. By the time you buy one technology and by the time it is on your door, you have a new one. So how you will keep on competing? Rely on your basics, rely on the basic fundamentals. Use whatever technology you have in hand, use the best out of it. You need trained technician to run the machines. It's a great learning curve. Every day something new needs to be learned. Expensive, it's very expensive, poor availability. So normative database is not yet available. So mantras to success is still the basics: availability, behavior, and competence of the doctor. Competence, your skills, your knowledge, your motivation, your attitude, and only a skilled health professional can cope up with the unexpected. Expected everybody can. And the machines will not, machines can only give you the expected. So machines can fail, but your fundamentals and understanding will never fail. So stick to your basics and be less dependent on the technology. Master your skills. While advanced equipments can facilitate surgical procedure, but skill and expertise of the surgeon remain fundamental. We all know that. Patient satisfaction, again, concentrate on this rather than keep on investing on huge equipments coming every day. Patient satisfaction, know your target population. Still in India, the majority of the population, 70%, falls in lower and middle class, and only 11% is the premium class. So you invest so much, you are waiting for the premium patients to come and pay the bills for your machines? No. You initial practice, you need to focus on the patients, which are, you have a huge group of patients to cater. So one satisfied patient is going to get you 4 new patients, and if you dissatisfied one, they are going to 10 potential patient will be lost. So invest in other thing, good online presence, strong system of operation, quality assurance to all sectors, be compassionate, be attentive to the patient, positive uplifting communication. Do not look upon the patients as your ATM machine. Build volume and then invest. So 70% patient will come back to you if you are resolving the issues in their favor. So good clinical judgment. Why will I invest in femto if I'm able to do a good phacoemulsification? If I'm able to give good results, rather than if the patient is little paying, I will invest in giving them a good IOL rather than facilitating the process of phacoemulsification. So I would ask the patient to invest and invest in a good premium IOL rather than adding 30,000-40,000 over the routine surgery and paying huge bills. So financial justification, where is the justification? Routine ultrasound still stands good. If you shift to the immersion, it's not necessary that you have IOL master 700 in your practice. It's still only in few. Of course, I'm not saying that technology is bad. Technology we improve, but then still you have things basic available where you can use them judiciously and cost effective. Gold mend is still the standard technique. Machines, if you have an artifact, who is going to read this? If you have a good clinical judgment, then only you can make out. No, machines are going to make mistakes. They're not man. Good gonioscopy is still, you don't need an SLOCT if you have good skill of gonioscopy. And LRI is still, able to correct mild to moderate astigmatism. You really don't need to go on the toric for 2 or 3 diopter of the astigmatism. So still you can cater such kind of patients where toric is not available or is expensive for that patient. So other things are also there if you keep on, this just never ending. So man versus the machine. So great designs come from the great designers, and it's the man who makes the machine. It's not the machine who makes the man. So use your brains, use your basics. If you know how to play a guitar, you can make a guitar out of the things available from your place. So leaping too far, too fast can lead to a death by ants. Not one bite is going to kill you, but thousands might. And clever clinical and financial justification, skill and expertise of the surgeon remain fundamental. And where there is lack of resources in a developing country like India, you don't need to depend on the expensive equipment. Please focus on the target population. You decide what you want and then move ahead with your practice.
Thank you, Dr. Anshu.
Thank
That
you.
was well said. Yeah, quick
Very
comment.
well said. I think she's nailed it. Basically, there's a time, there's a place, and there's a person. So you have to, there's something called incremental cost effectiveness ratio, the ICER. So do an ICER analysis, shift to the newer technology if it is favorable, if it is not. Now your ICER also depends on the place where you're working, right? So having a blanket approach that, employing technology has cut the costs of delivering the service. That is the truth, especially, and ophthalmology is the biggest beneficiary of that. But going forwards, the incremental benefit for every new technology it's a small increment of benefit that is there. And if you are working in a place where you'll be able to generate that much revenue to cover the cost of that incremental benefit you're going to get with the new technology, go ahead, invest in it. So it's
Okay,
a no-brainer.
Dr. Rajendra sir.
Focus on your core competence and do an ICRN analysis.
Quick
Very
comment.
nicely spoken.
Thank you, sir.
My simple advice is when you are in private practice, first earn with the basic instruments. If you have money, then invest on the premium instruments. Don't take the, as she said, IL master in the beginning itself. You have a good ultrasound machine first. Do some FECOs, 100, 200, 300, earn some money and then invest on the. But definitely, because see, these devices, the newer devices is very important. You should have IL master because we are going to practice premium IOLs, especially the multifocals, trifocals, torics. You cannot do with the basic instrument. You have to have, but not in the beginning itself. First, generate your patients in your practice. You should have at least 20 cataracts in a month. If you are doing that, then in a year time you can buy IL master cell.
Okay, well
So
said,
that is
sir.
the idea.
Yes, sir. In the meantime, the next batch, please be ready. Yes, sir.
You are a very good debater. If you had been the first speaker, what you would have spoken is an interesting thing, because you have the power of convincing. But having said that, it's good to go for technology, but not at the cost of financial losses or
Yes.
burden. One suggestion is all these equipments can be bought on shared basis.
Yeah.
So 10, 15 clinics, if they join together and buy one IOL master, it can share. It can do up to 1,000, 5,000, up to 5,000 scans it can do a month. So it's such kind of approaches.
There are
Available on
refurbished,
rental
and
also
refurbish
nowadays.
is also one of the option, and there are rentals
Rentals
machines
also
going on.
available now.
So
Correct.
we also use rental machines. I'm not against the technology, but only thing is you have to judiciously decide
Yeah.
whether you are in a position to invest right now or not.
Yeah.
So if you are not,
Unfortunately, today, the costs are exorbitantly high. So, and hence sharing is one way forward.
Yes.
While you should not stay away from technology. If you
Yes.
stay away from technology, I think, especially at the present pace at which things are changing, you should be in line with technology.
we should
Point
we
well
should
taken.
be.
I think
should
let's
look
move
for
on
other
to the
options.
next because the
Last word. I'm in practice now for the last 30, 35 years.
Dr. Anthony,
And
please come.
I have today each and every latest instruments, but only for the last, I think, 10 years. 20 years I practiced with the basic instruments and took these premium instruments only for the last 10
So
years.
each person has to think for himself,
what I mean to
whatever
say-
situation you are. I think each person, not one thing will be applicable to everybody. So judiciously do whatever
Yeah,
is
the
possible.
cost and
So
the revenue.
let's,
Just work out your costs, work out your revenues. That's
yeah,
it.
let's move on to the next, Dr. Anthony versus Dr. Devendra Venkatramani. And I would also like the next, Dr. Chaya Bharti and Dr. Ajit Dwivedi. Yeah, be ready.
Good afternoon. I'm going to talk about moving away from packages towards fee for service is necessary for long-term sustainability. And I'm going to say, yes, you have to move towards fee for service and not stick into packages. I thank the ARC for having me here. I'm Dr. Anthony. I'm working as a pediatric ophthalmologist at Bejan Singh Hospital. And at the outset, pricing a service is not as easy as pricing a product, but it is very important because it can make or break anyone. As the poem of Robert Frost goes, there are always two roads that you can choose from, and the often used one is not always the right one. Okay, so you can price the patient who comes to you as per the services you have rendered to them, and for each service that you've rendered, you can bill the amount and you can ask them to pay for it. So that is fee for service. Or vis-a-vis, you can actually define a package in which all the tests are there, and then you ask the patient to pay for you. So that is the package thing which is there. So I'm going to talk for the fee for service, just as the plus sign says, because it is effective and because it is good. Why? What is the biggest problem that people who are against packages, against this fee for service have? You know, the biggest problem that they have is we are going to start earning more. Is anyone feeling regretful about it? That you're going to earn more because you will charge for each service that you're offering the patient? It is a happy ending, right? Good. So, is it wrong? No. See, why I'm saying is that many times how do you decide on what you're going to charge the patient? Many times you just ask in the industry what people around you charge and then you charge it off. That is all. But actually it is not the way. That is okay. That is one thing that you have to do. Discuss about what is the commercial thing going on around you. But you also have to look at the so many costs which are involved in it. You have to look at what are the fixed costs or the variable costs. And then this is a paper from Arvind in Community Eye Health as to how you should cost you. So many things you have to, but we don't look into all this. That is what I want to say. The thing is, you may tell, if you bill for each and every service that you're going to offer, will the patient feel bad about it? No. If the patient understands the value of the test, he will be ready to pay for it. And you would also reinforce the importance of these tests to the patient. Nowadays, cataract surgery has become like getting a facial done in the beauty parlor. So they consider it like that. No, it's not right? Actually, it has a value and you have to convey it to the patient properly. Unless they pay, they don't know it. I'm going to ask all of you a question. How many of you know that there is a QR code scanner in your card, behind your card, to access the program schedule? See, only few of you know. Most of you didn't turn it and see. Because if they had told you, we are charging 1 rupee for that, at the outset when you registered, you would have known it, right? So that happens to many patients when they come when you give it as a package, they don't know that they have underwent a NCT, they don't know what they have underwent a AR, they don't know they have underwent a keratometry, they don't know it. If you tell them, I'm not telling you to ask them to pay you at each outset, each point, touch point, no. At the end, when you're billing it, put it in the bill. This is the charge for this, this is the charge for this. Then when they look at it and when they know that they have paid for it, they'll understand the importance and the value of it. So that is what I want to say, first point. The second issue with it is, please consider this example. On one point, two patients come to you, both have paid 300 rupees. Sorry. Okay, one patient has just OPD and the other in so many investigations, and both pay 300. Suppose you tell the patient who has not underwent all these investigations, you're supposed to pay 300, but because you did not undergo all these tests, I'm taking all that amount from you and I'm giving you lesser cost. See, they'll have a goodwill about you, and this goodwill is what is going to sustain you for the long term. So they'll know that I'm paying only for the services that I'm receiving. I'm not paying for something which I've not received. So that is good about it. And third is, you will know what is the return for what you have invested. So each machine you've invested, put money and invested in, how will you know how much return have you got from that machine unless you bill it separately? So with all this, I'd like to say that moving away from packages towards fee for service is necessary for long-term sustainability. Thank you.
Thank you, Dr.
Warm good afternoon to everyone. It's really quite warm in Kochi, but I'll try to minimize everyone's discomfort by keeping my talk within the time limit, as long as it can open on time. I could not agree less with my opponent, the third one. So it took us a little bit of research to actually understand what is fee for service, and what is packages. Now we've discussed this, Anthony has gone into all this, but basically these are methods of reimbursement or methods of billing. Now, we live in an era where we have different people who are paying for the service. It may be the patient, it may be an insurance company, it may be the central government health scheme. So these are packages, for example, of a cashless surgery, whereas in a fee for service, just look at what CGHS offers in ophthalmology. Now, you've charged 500 rupees for a consultation of a patient who has come with glaucoma. You've done the NCT, you've done the, gonioscopy. But if you have to sit and add 8 packages which you would have anyway done and send it to CGHS, you require one more person for that. So you are going to pay for more manpower, you are going to pay for more documentation, and you have to sit and waste your time and break your head on that. Now, most of our patients today are still luckily uninsured, and we are actually following both of these systems. We are both doing bundling and we are doing fee-for-service. Now, when you have a complication during a cataract surgery, you are not going to sit and charge the patient for the vitreous cutter that you used, for the triamcinolone acetonide that you used to check whether the vitreous is there. It's part of your package. You may wish to hide those costs. But suppose you are on a fee-for-service model. You have to tell the patient that I used a vitreous cutter because you had a complication. I used the IVTA because of this reason. I used this extra visco because of this reason. Why do you want to sit and break your head and explain to each patient? When you talk about explaining each test, suppose a patient requires NCT, are you going to sit and educate the patient? You require NCT because of this. You require a gonioscopy because of this. You require this. If it's part of your bundle, it's your flexibility as a practitioner, whether you wish to disclose all of these things or not. Now, in India, this is the number of patients who are actually covered with medical insurance, and we are dealing with a very small subset of patients. Always fee-for-service will have more cons, and most of it will have more cons simply because, look at it, you require more paperwork, more accountability. The premium that the patient pays is always going to be more expensive, whereas with a bundled care, there's going to be a lot of advantages. I'll tell you why. From a doctor's perspective, fee-for-service has much more paperwork. Like I said, you need to justify. When you send a patient for insurance and he has a complication and you put vitreous cutter, you need to sit and explain to the insurance company why you used a vitreous cutter. Are you as a doctor not demeaning yourself by explaining why you did a particular test or why you required a particular extra procedure? You may not be sure that the insurance company is going to pay you for that extra procedure. Most of these packages will disconnect, they will disconnect some treatment decisions, which makes it advantageous for you. For example, if you know that you are going to do a cataract surgery and you are not going to be paid extra in case there's a complication or you have to absorb that cost, you will be taking much more care in your surgery. You will be making more ethical decisions, and you will have provided better quality of care. And this has been proven by studies done in the US, where 40% of the patients are of fee-for-service, and now they're all being forced to move on to bundled packages because of Medicaid. From a patient's perspective, if you do a fee-for-service, the patient may be subjected to unindicated procedures simply because the insurer or someone else is paying for those. So I'll conclude with this, that this is the predominant payment model in the US. It's the most expensive healthcare in the entire world. Where is the question of long-term sustainability with such a model? Now, I think we all remember this incident 4 years ago, where Rahul Bose's bananas were charged extra. And this is a fee-for-service model. He took a room in a 5-star hotel and asked for 2 bananas, and they charged him 442 rupees inclusive of tax. Are you going to sit and explain to the patient why you are charging extra 100 rupees per banana? And ultimately your patient will say, "Arey baba, bina chilke ka bolo na." So you are going to sit and bargain with the patient that mera itna kam karo, ye test aapki zarurat nahi hai. You are going to break your head in a fee-for-service model. Always go for a bundle package.
Good points. Yeah.
Very nice debate. I think this was the debate which should have started all of it. Actually, it's the balance between convenience. Most of the patients are onto insurance models. We are following the insurance model. So obviously, everybody wants convenience, the paperwork to be less, even though, you still need somebody to do your paperwork, even with the insurance models. If we had been following fee-for-service, we would never have had pressure from insurance companies. The moment you standardize your packages, now you're going to take a beating on the cost of each of those packages when they become more easily available. So that is the minus of it also, but the convenience is there. But I think I'm in the government sector, I would be
Dr. Prasad.
really...
I think it depends on the type of the patient, especially you're dealing with, whether it's a government sector patient or the purely private patient, cashless or with cash. So this makes all the difference, because if you have a cashless patient, then you have to definitely do all these procedures. If you have a with cash patient, then we give the package. Then the package is always better, like what you spoke, because you don't have to explain each and everything to the patient. If you try to explain, that gives you a negative effect also.
Absolutely.
Yes, so it all depends on, yes,
Be sure that what type of the patient
what
you
is
are
the
taking.
setting, what are the costs involved, what exactly is the situation, and then we can discuss. But good points for to and fro. Come.
And when we reimburse, even in the government sector, you do get these a la carte packages. So it takes a lot more calculation. So the bills which are bundle packages, they are immediately passed, and those which are a la carte, those totals are checked and matched. So it takes longer.
Dr.
Especially
Ajit
the
Dwivedi is
CGHS
here.
patient I have seen, because you spoke very well on the CGHS patient. I have seen the patient billing for the digital tension also. It looks so pretty, like the doctor has gone so down. You have seen the patient, you just charge whatever they have given the charges of 100 or 150 rupees, but you just want to increase your charges. You put, I've done this, I've done this, I've done this. I've seen 15 numbers in the bill, and then finally it's coming 400 rupees. So what is the status you are putting yourself into?
Yes, so let's, okay, last comment and then we'll move on.
See, this is an important topic because this dwells on the finances of the hospital. So here, whatever services are giving, packaging is convenience, but it's never good. Only thing is we can use a hybrid model. We use the hybrid model. Whenever we do packaging, we tell them if it's for a routine cataract surgery, this is what it is. But if there are other parameters like comorbidities, a small pupil, exfoliation, like a hard nucleus or whatever, so or you have to use trypan blue, everything, whatever. So then it's going to be an additional cost. It's good. And regarding that vitrectomy, there's no harm in saying that we did vitrectomy. In fact, in my practice, I don't know how you take it. When we do vitrectomy and put an IOL, we charge around 5 to 6K more. Because then we are able to afford a good cutter, extra time and final care. Finally, we can't take patients' problems as our problems. We are only solution providers. Problems can happen statistically, but we should be in a position to sustainability was the key there. And hence, I request people to go with the mindset that you have to have a hybrid model.
Okay.
Packaging is convenience, but loss of money.
Okay, I think let's move on. Actually, we have 10 more. We have a lot of debates ahead, and I think we'll have to be very quick in this, otherwise, we won't finish in time. So, coming
I'm
on to
going
the
to
next,
take this-
Dr. Chaya versus. Actually, it was Dr. Deepti Chauhan, but Dr. Ajit Dwivedi has very kindly consented to speak on her behalf. Thank you so much for that.
So I'm going to
Yeah.
take this talk forward, and my topic is that I'm going to talk in favor of TPAs and not falling in the government subsidies. This TPAs are consist of many health insurance policies, and there are so many health insurance policies available these days. But the government subsidies, there are 15 to 17 types of government schemes like Ayushman, ASIC, and DBCS. The TPAs are of high packages, no brokers involved, no incentives has to be given, no mediators involved. And while the government subsidies, they have very low packages, may not even get refund. And sometimes you have to go, this 12th pass clerk is sitting over there, हाथ जोड़ के अरे सर मेरा पैसा वापस करा दो, थोड़ा पैसा दिला दो, आप 20% ले लेना, आप 30% लेना. So these issues has to be, I just want to rule out these issues. So, and if by chance the patient gives a negative feedback about the doctor, about the staff or the hospital, then your policy will be withdrawn. But in case of TPAs, we get charges for pre-hospitalization, operative charges, ambulance charges, post-hospitalization, even the preventive and the investigations are also paid. But for subsidies, there is long 3-day stay in which you have to give food, glasses, transportation, everything has to be free. And even in some subsidies, cataract may not be involved. These subsidies involve low socio-economic population which get lost to follow-up and they don't want to pay for consultation. The refunds are very slow, incomplete, time-consuming. So to have a peace of mind, I would like to go in favor of TPAs. So tame the TPAs and not to fall in the government subsidies. Thank you.
We'd like to welcome Dr. Nitin Balkrishnan, who is our expert panel. Welcome to this debate session.
So, good afternoon, and everybody is already full of debates. So it's I just came to know that Dr. DP is not here. No. So it will be direct debate on me, not on our board itself. So Dr. Gayatri has already, Dr. Chaya has already set the stage and everything she has already told. So I am in favor of taming of TPAs, and I feel that even the government is also a TPA. Why there is a need? Because the whole of the our population, and where we are going up, we are covering 40% below the poverty line, 40% of the population with the Ayushman Bharat, and above that the middle class that buys the insurance with the corporate sectors they are giving, and they are also a kind of aggregator which is taking health insurance as a bulk, and there is the higher class which is paying. So once you are starting a clinic, uh, gradually you are not getting patients, I can say, because we have a large population and many are very much uneducated and unaware about this health insurance sector. So they are not going for that one. But there is a word of caution. If we are going for the insurance, we are going for the TPAs, we should take first of our healthcare, clinical care cost, clinical care standard, our way of delivery. No.
No, he has not
direct
prepared
debate
because
on me.
he's
So it's
extempore.
extempore, yes. So once we are going for these sectors, so we should always calculate our cost, our standard of clinical care, and it may be different for each of us. Someone is working in an institutional setup, someone is a second generation, some is a fourth generation, they have already accumulated wealth. I'm a first generation ophthalmologist doing private practice, having 2 hospitals, and accumulating TPA. So I am understanding that part. I have Ayushman Bharat too. But don't fall prey to their taming activities. You decide your own package. You decide, they always ask for the subsidy. We decide our subsidies, our cost. We share the profit. We share the profit to some extent, not to at their own benefit, because it gets, as Dr. Chaya has already said, it gets additional cost. Initial discussions already tell that it is creating additional cost. So we must invite TPA because it's a need and of our future of the healthcare. So we have to get them up but not fall prey to them. That's my point.
Excellently put forward by both. Quick word of from Dr. Rajendra Prasad sir, Dr. Rajshekhar sir.
Well said, Doctor.
Dr.
Really, both of you spoke very well. And the basic fundamental is the TPAs are creating problem. And in our practice, because many of the institutions, I think, especially in Bombay or rather Maharashtra, they have already fought against the TPA, and they are doing all cash, like they are not doing the cashless. We in Delhi, I being a president of DOS now, we are fighting a case in the High Court against the TPAs, and we are trying to get away from the TPAs, and we are definitely in a few months, or say within 6 months, our state is going to be cashless free.
Definitely, and at the same time,
that's why it comes with everything. The GIPSA also comes
In the meantime,
medical
Dr. Samendra Kakur and Dr. Siddharam.
And also, when the packages was decided
Please
in the
get ready.
beginning itself, it was way behind, way before, and by the government sector people. I'm not saying anything.
That's
and
true.
the technology has changed.
Yeah,
the
because
cost has changed.
we have
So
put
why
so
not
much
to
of-
revise that one?
They are not revising. They are not revising, and they are forcing to work on the packages what they
Definitely.
have given. Yes.
Do we have the next team, please? I think Dr. Shalini Mohan has just gone out for. Is your talk loaded already? After this, Dr. Neha Deshpande and Dr. Tripti Kadam,
Good
please be
afternoon, all.
ready.
My topic of discussion will be compliance to NABH, which is a boon. I'll keep it very simple. Just I'll list out the points. So it is a board for hospitals and healthcare providers and constituent board of Quality Council of India. The program is for healthcare organizations, and it is also a board member of the International Society for Quality in Healthcare, ISCA. It's a voluntary process, sets standard and benchmarks in quality healthcare delivery, and the compliance is met through a rigorous evaluation. Emphasizes on patient safety as a top priority, safety protocols and systems are implemented, and provides safe and secure environment for the patients. It enhances the quality of care and improves patient safety. Competent healthcare professionals encourages the implementation of evidence-based best practices and reduces the risk of medical errors, infections, and other safety-related incidents, which are very, very important in ophthalmology-related services. It ensures efficient and standardized systems, leads to reduced waiting times, improved operational efficiency, and better resource utilization. Patient-centric approach is at the core of NABH accreditation, and emphasizes on communication, respect, and involvement of patients and their families, and it helps train all the healthcare staff associated with the organization. Prioritizes patient satisfaction and feedback. It improves organizational efficiency, implementation of quality management systems, and these hospitals eventually have effective leadership, proper documentation, and continuous improvement mechanisms. It increases trust and reputation among patients, assures patients and stakeholders' commitment to quality, and these hospitals gain a competitive edge in the market against those who are not accredited. It ensures compliance with legal and regulatory requirements, adherence to various national and international standards, and reduces legal risks and litigations. It also provides an open door access to government schemes and insurance networks. These hospitals are preferred by government agencies and insurance providers, and helps in collaboration and networking opportunities with other accredited hospitals, not just nationally, but also internationally. We share best practices and can learn from each other. It provides global recognition in medical tourism. The hospitals can attract medical tourists from across the globe seeking high quality care. It contributes to the growth of medical tourism in India. So let's strive for excellence and contribute to a healthier India by getting NABH accredited. Thank you so much.
Very well spoken. Let's have the next contestant. Yeah. AV team, can you please help him?
Okay, NABH compliance. I am talking against the NABH compliance, that is bail. Okay, most of the time we are living in the developing country. That is, India is a developing country with blindness around 859 million population, and that more in the rural population. And it contributes to only one ophthalmologist for 70,000 population. That too mostly they are practicing in urban population. Okay. Here, different type of practitioners, single doctor practice, group practice, chain of hospitals. But whatever were policies government will bring for urban peoples and network and already established and corporate hospitals, everything they can bring the policies and you can implement it. For money generations or finance and all these things will talk. But most of the time we will not talk about rural peoples. But so many peoples are blind. If you are bringing this all accreditation, nobody wants to practice in rural because there is no profit. When you implement this, what are the challenges will come across NABH accreditation? I will go through it. One is, first is lack of resources, that is finance. If you go for like NABH accreditation, there will be around 2 to 5% increase in the expenditure. Okay, that will cost on patients, even individual practitioners. Okay, where this investment or resources will go? One is maintain the infrastructures. Most of the individual practitioners or small practitioners is practicing from 20 to 30 years. Suddenly you are asking for NABH accreditation. You can't demolish that old hospital and bring new hospitals, new staff and new equipments and training of the staffs who are is working for 20 to 30 years of the same with dedicated their life for our hospitals. And now this is like small practice and individual practice, this unnecessary things like HR, finance consultants, legal experts, and information technologies, most of the time it is for corporate hospitals. You can't put for rural, especially individual practitioners. And if you see the hospitals, that is what I already mentioned, it's old hospital, you have to convert to new hospitals. There is more expenditures. Time. Whenever apply for NABH accreditation, you have to spend time in that. You have to make like complex documentation and structural changes. This makes like hurdle for all practitioners. Resistance to change. You can't easily motivate the person staff who is working for 20 to 30 years. Okay, that is very difficult. And you can't remove from the job because they are dedicated life for our individual growth and our hospitals. Limited resources, especially in rural areas, there are limited resources available to upgradation of the hospitals. Training of the staff. This is first you have to identify what is the lack in that for working in the hospital and how to train them. It again make cost for our hospitals. And managing this is one more drawback is managing employee time to allocated for training without affecting the patient care. Because individual practice, small practice, there will be 10 staff only. Okay, you can't like send for training. If you send for training, that will affect the patient care. Okay, how to manage both. There will be so much, there will be 300 points for NABH accreditation. You have to maintain that. It's again difficult process whenever going for accreditation. And there is doctors are usually clinically oriented, and you are converting to administrative power, and you have to spend both life, clinical practice, administrative, family time, everything. It is very difficult for especially small practitioners and individual practitioners. Take home message is it cost, human resources and infrastructure will overburden the developing and rural part of the India. Thank you.
Very well spoken. A few comments from Dr. Nitin Balakrishnan.
I think both the speakers had their points, but the few things is change is the only constant. So I think it's important that we have to accept that NABH is here to stay. And even in rural areas where it's not so difficult as you pointed out, I think an entry level NABH can be done even without changing the infrastructure. Staff training is something which is very beneficial. On the other hand, the other important point to make is the NABH protocols which we follow shouldn't be followed only during the process of scrutiny. And one should insist that that has to be continued all through. It's very often we see that it's being followed only during the process of scrutiny for those 2 months. And after that, everything is forgotten for the next 2 years.
Okay, this is for debate. Everybody has to follow NABH accreditation. Thank you.
Very well spoken. Let's have the next team.
So good afternoon, everyone. I'm Dr. Neha Deshpande from Nagpur, and I've been talking in favor of extended waiting time for patients is the outcome of biting more than we can chew. So before we start, we all know this, right? There is an input of patient coming with the complaint, then he's processed by multiple things like refraction, fundus examination, and at every point of time, there is waiting time. After that patient comes out, he's processed with the, the resources like doctors and staff, and of course, at the some cost, very costly land place, and of course, with the instruments, and all this is run by information structure. This is what we call a process. Waiting time can be divided into a useful waiting time like dilatation time, or a wasteful waiting time like patient is dilated but still waiting for consultation to happen. So this is basically, even though it is an internal measure, it definitely affects directly your patient satisfaction and retention. There are multiple methods with which we can actually track this waiting time. and whether the patients are affected or not. So what we did in 2019 when we had our second NABH inspection, we decided let's measure our waiting time. But first question came, is it really bothersome to our patient? So we did some study and we found out that yes, patients were bothered. We were having waiting time more than 30 minutes. That means 50% of the times patients were waiting rather than being utilized. And what's causing the problem? So there were some bottleneck issues like perimetry, consultation, billing. These were issues, or there were some resources less at some specific points, or there were overburden to doctors. So there were multiple suggested changes. We followed these 5. What was the result? We were very happy. We reduced our waiting time from, of course, this is wasteful waiting time, from 32 minutes to 11 minutes with our flow time efficiency.
Can you go back to the previous slide?
Sir, outer looping we did means many a times when patients come to us with just for the examination, and we find that patient is having glaucoma, macular edema, diabetic retinopathy. But next day, if you call the patient for the investigation, the issue becomes that patient has to be dilated again. So we started outer looping things, explaining patients what is to be done. If we have time on the same day, we will finish off with the fundus photo and OCT. Or reducing the load on doctor by cross-training the people. Like we had only one person who was doing perimetry. If she was busy or she was absent, everything will just crumble around. See, it's a very private practice with 10 staff. So we decided, no, everyone will do perimetry. Everyone will learn OCT. And that's how, we started cross-training people. We reduced patient movement. We have a OPD at a ground floor, and third floor is our investigation room. So we reduced the movement of patient. Patient will come, report, and immediately will be taken to the investigation room. Investigation will be completed and then got down. So intermittent movements were reduced. Then there was a pull and push strategies, which are explained, which are like pull strategy is like the person who is in charge of the investigation room will call them, I am free, now you can send the patient. So these are the few points. So outcome was there. What is important is next. This is what happened later. Because quality, it is our quality indicator for NABH. So we continuously monitor our waiting time and see the fluctuations. The reason can be multiple. There can be sudden surge of patient, machine might conk off, your staff might be not there. And therefore, I believe that yes, waiting time is more than we can chew because we work in a service industry. There is inherent variability in everything. There may be a variability in patient flow system, like you expect only Monday and Saturdays being busy, but suddenly on one Wednesday you will get 30 patients. Or there can be variation in patient types, 2 patients, 2 head-eating patients, and all the waiting time for your next patient has gone up by like 15-20 minutes. Then capacity variation. Staff will go on a holiday because there is pain in her hair or nail, you don't know. Or, machine issues. Or process monitoring failure. This is best. Doctor gone, not there for one day, and sister will take 4 breaks. Breakfast 1, breakfast 2, lunch 1, lunch 2, and whatnot. And your whole waiting time is gone. So I will just stop here because we are all pressed for time. We should not be waiting for anything else. Thank you.
Yeah, good afternoon, everyone. After this post-lunch session, most of the points were covered by Dr. Kamal Kapoor as well as Neha also. So my talk is about no, not at all. Given the facility, even the patient can wait more and can have a quality service from the doctor as well as from the other team. So as we know, like according to the WHO, waiting time is the one of the most important key measurement of responsive health system. So it starts from arrival, waiting, consultation, and departure. And it's an important factor for the patient's dissatisfaction as well as discomfort. And if you have long waiting time, abilities to attract business decreases. So this was a survey where they said that there is a significant relationship, inverse relationship between the level of patient satisfaction and the duration of the time spent at the service station. If a doctor is able to spend a good time with the patient and counseling him in better, the patient satisfaction is 93%. While the front desk and the nursing staff giving a good care can give a satisfaction of 83%, And if we do the ancillary test and other things, the satisfaction goes up to 43%. So as Neha has told that there are front desk problems, there are back desk problems, the patient workup problem, the ancillary test. These are all the reasons which are there for the patient's dissatisfaction and increased waiting time. So I won't be enumerating all these things, but I've just incorporated. We can have surgery delays also because of the equipment failure, procedures, process, people around, and if there is a management related problem also, if the communication is not there. But yes, we can bridge that gap in spite of waiting long by such, like, we can have a registration through a Google form, or we can, on the arrival, we can give them a sheet to write, and that data can be entered. They don't have to stand in a long queue. The documentation can be done by the front desk workers. We can have an alternative form by tagging the patients who are high risk, like who has a comorbid status, by tagging them as Dr. Ritika said, which are the cataract or the refractive thing. The strict no-show policy, we should schedule the spoilers. EMR systems can be used, television, and main thing is like streamlining the clinical outflow by moving less, means having the patients at one station and 3-4 machines at the same place and decreasing the time. That can be done. And communicate about the delays. That's what Dr. Kamal Kapoor has also suggested, that appointing the patient care, providing vaccines, and we should have a patient feedback. So these are the institute things, and this is at the solo practice level where can we provide an entertainment, and we can have non-invasive method and increase more output also, and we can have a survey and a surgical checklist to have more that. So at the end, patients are the key to your long-term practice success. Thank you.
Thank you very much. Can we have the comments of Dr. Nitin, please?
I think both the speakers covered very relevant points, and it's something which we need to improve upon. All of us in our practices have this problem, and like Dr. Lambat mentioned, if you have 2 or 3 patients who are who want to have a longer discussion with you, it can really derail the whole system. Yeah. So one needs to check in individual practices how to streamline the process.
I don't know how Dr. Kamal Kapoor was saying that his turnaround time is 52 minutes only. Beyond that, the patient is not there in sharp sight. I don't know how he manages that. But anyway, thank you for the wonderful,
team ready? Yeah.
Wonderful presentation. Can we call Dr. Shalini Mohan now?
Yeah.
She'll be speaking on online video consultations as a model for teleophthalmology is underutilized. Yes. Thank you. Thank you so much.
Thank you, Chair, and good afternoon, everyone. So my topic is online video consultation underutilized, and I have to speak for it. So is it a reality today? Particularly patients in remote locations with limited access to standardized healthcare. Yes, it can be a reality for them. Important factor responsible for growth in this field is increasing use of smartphones. Now everybody is carrying smartphones, so obviously they can have video consultation, and in fact this has been approved by WHO, and it is a new normal. Now it also removes the geographical barriers to healthcare. So is it really useful? It can be done anywhere, anytime, and convenience at its best. There no transportation is required, and patient actually saves the money also by video consultation. Therefore, it is cost effective, and there is no exposure to hospital acquired infections also. Moreover, you can easily reschedule it or transfer from face to face, and the family can also join in. Other consultants can also rope in, and therefore, technology has actually made it possible. Now, let's see an example, if we can click a photograph from the slit lamp, we have mobile cameras available, and if we can click a fundus photograph and then we can send it to a person or an expert who's sitting far beyond, obviously he can make some certain differentials, and then you can post some or more photographs, and consultation can be done very nicely. But is it underutilized? Of course, yes, because there are so many challenges involved. There is no insurance policy for doctors in such cases. How can you take informed consent if you want to? Moreover, 3/4 of the population is sitting on the remote area. They are not aware of the online payment modalities, especially in our country. is there any dedicated apps or website which can actually help us? Like I am in a tertiary care hospital, a government setup. We don't have any facility where an online video consultation can be arranged for our patients. So when a tertiary care center in a hospital it is not available, how can we expect this to happen at a rural setup when most of our population is residing there itself? Well, if you talk about smartphone, there is 43% of penetration of smartphones in our population. And what about internet availability? 48.7% people in 2022 have access to internet. So obviously it is very good, it can be possible. But then here in this convention center, how many are actually able to talk on the phone nicely? Is there not internet connectivity issues? It is not a problem. I am trying to contact so many of my guys, so many of my friends, but I am unable to do even on phone. So how can we expect online video consultation? Yes, of course, it has to be underutilized. I'm pretty confident that my colleague will show you certain figures like this, that India recorded 3 times increase in online concentration, 5% increase in online concentration. But my dear friends, this is about online consultation which is not video but it is audio. Moreover, when we see this very important graph, this is about other specialty. Just have a focus on ophthalmology. It is just 1% in 2019 and it increased to only 3% in ophthalmology. So in ophthalmology it is only 3% video consultation and it is extremely underutilized. Of course we can make it more useful for our patients. Thank you so much for my kind attention.
That statistics was of the Practo company only.
Yes, sir.
That last graph was of the Practo company only.
Sir, there are so many graphs like this which are available online. Anybody can search it. So it was just an example to show. And in ophthalmology, especially in ophthalmology, it is very much underutilized because obviously we need gadgets for that, to take an interior segment photograph, to take a fundus photograph.
Correct.
So that is why it is very much underutilized. Especially for physicians, it is quite commonly used that people just have a talk and then they can have online consultation.
Thank you very much.
Thank you, sir.
I'd like to call Dr. Ramesh Babu Bobli. Sorry.
Yeah, good afternoon, everyone. I thank Dr. Chitra ma'am and team ARC for giving this opportunity. I'll be talking on online video consultation, underutilization. No. And obviously, our ophthalmology is technology and image based. There is hardly one ophthalmologist for 70,000 population, and among them, 70% of the ophthalmologists are practicing in urban areas. And this one, teleophthalmology, gained momentum recently because of ongoing COVID-19 pandemic. And we can clearly make a diagnosis while examining wide intumescent cases, dense nuclear traumatic cataracts with online consultation only, and we can ask them to consult the base hospital. And of course, emergencies like phacolytic, phacomorphic glaucoma, corneal ulcer, conjunctivitis, of course, allergic conjunctivitis, chemical, dermal, open, closed injuries, computer vision syndrome, and it's a well-known fact that diabetic retinopathy is managed well with help of teleophthalmology. According to a paper published in 2021, almost there was 10 times, 9.2 times increase in OPD consultations from a developing country. And one more thing is relatively higher percent of service utility among females and younger age group and people of higher socio-economic status who were little reluctant before. And most common indication for consultation was red eye. So when the telephone was introduced for long distance in 1982, Rutherford Hayes, former US president, said it is an amazing invention, but who would ever want to use one? That was his thought on that day. But you know what the technology came across now. This is a change curve. One need to understand. First, initially,
for there is a learning for both doctors and as well as patients. So there will be shock and denial, and second one they will reject first initially, and they will try to bargain, and ultimately depression and accept. So probably our counterpart was in this ways, in this way. That is the reason she was unable to accept, and that is my argument. Thank you.
Thank you very much. Anybody has any specific views on this? Online video consultation?
The problem is because of COVID it came to existence, but nobody is using nowadays. That is the problem. That need to be in continuous effort. That is the thing.
You can cut down on the travel charges, their food charges. They come down to a district quarter, they have to spend on a breakfast, lunch, 100 rupees. A consultation from their village just for 100 rupees or 50 rupees will do the job. Done in a nice way. As first photograph of madam was a fundus photograph also. Now in web consultation in Aravind, they check the intraocular pressure, they do refraction, they take reclam photographs, and then they do the fundus photographs also. Everything is available. So if that is provided, then that will be a very good.
Why are we only focusing on rural patients for online video consultation?
What?
We can access medical tourism via online video consultation. You have such a long waiting period for someone to go to a glaucoma specialist in England under NHS. Why are we focusing our video consult on rural, where you're talking about online consultations being a challenge? You can also funnel your expertise into the UK, to Middle East, to Yemen, to Syria, where money is not an issue. Sending you online payments, you can figure out, you can get a PayPal account, and those people know how to pay you. And at the same time, those people will eventually visit you when they can. So you're also growing your potential for medical tourism. So why only rural are we talking about?
Brilliant.
Online is online.
Government of India is looking for you.
It's a medical tourism, but at the same time, in ophthalmology, the things get corrected very fast, and at the same time, it worsens very fast. So there should be a word of caution. Definitely, Arvind and other institutions can do because they have an infrastructure. They have you can add online consultancy to your regular consultancy, but you cannot bank on only online video consultancy.
Because the infrastructure cost has come up, they have modulated a specific adapter for the slit lamp. The cost of the adapter is 3,000 rupees. You can fix your smartphone to the adapter and you can take it. And they have also made a special to keep the ruby lens, so that at particular distance, so that the fundus photograph becomes a fundus photograph, a validated fundus photograph.
Okay, thank you, Dr. Ramesh Babu. We'll move on to the next paper.
Just a comment, Satyajit, if you permit.
Sorry, please.
See, this online, I think the practitioners who are busy otherwise are thinking it's not possible and things like that. But there is one group of doctors who are already doing it, very effectively doing it, and public at large are reaching out to them. So I had one patient who came with a prescription, entire prescription written out for an online consultation. He was sitting in a hospital. In fact, he was with his father in an ICU. He had an eye problem. So he couldn't get an appointment in the same hospital. So he took online, and somebody from Delhi, Gurgaon sitting, has given him a prescription. And it worked. He had a sty and it worked. So there are one list of eye diseases for which you can give an online consultation. There are one list you can't.
Correct.
So that
Correct.
list will continue to be there forever. So, but whatever we can know, it's better to say yes and go ahead with that.
Okay, thank you very much. I would like to invite our next senior ophthalmologist who has a session to catch, Dr. Swati Agarwal. And she will be speaking on eyeing the low-hanging fruit in ophthalmology is enough to rake more mullahs. Yes.
Okay, so coming to the topic, what are high-hanging fruits? Well, oculoplasty, retina surgery, cosmetics, aesthetics, cornea, and eye banking. And what are low-hanging fruits? Well, those with high prevalence, high yield. They save time, relatively needs lesser effort, like cataract, refraction, refractive surgery, glaucoma, and India being the diabetic capital, anti-VEGF injections. Well, so are these low-hanging fruits enough to rake more mullah, more money? Well, enough to send you on weird rides and sit on chicken nests, play with cobras, watch international cricket matches, and hold peace flowers and give peace talks on the social platform. Well, but what about, say, Dr. Nilesh here, or Dr. Shuven Bhattacharya, or our esteemed scientific committee chairperson, Dr. Partho Vishwas? Well, they are VR trained retina specialists, but they primarily eye and practice cataract and refractive surgery. Why? Because they, along with the other who's who of ophthalmology, are smart. So be smart to eye the low-hanging fruits in ophthalmology because it needs lesser time for the procedure, higher quantity and turnover, and more money. Easier to convince patients, and you can always tell the patients it's a very simple, easy procedure, more conversion, and more money. Whereas for more complex cases, patients are more likely to be choosy in selecting the doctor, which leads to a lesser conversion and lesser mullah. So in other words, low effort, high yield, more money. So just like the fruits can be served raw, sliced, fruit salad, custard, fruit cake, and so on, similarly, cataract can be dressed and designed as SICS, phaco, microphaco, femtophaco, toric, EDOF, multifocal lenses, and so on. Well, all to suit the patient's needs and desires and make more money. So, do not shy away from analytics. Make an EMR system, analyze what the patient wants, remind them of the follow-ups, helps in customer retention, and rake more mullah. Well, working without analytics is like spending months in the burning desert without compass, without directions, and then finally finding a pyramid with a few mummies and a ton of gold, but all you come out with is some low-light selfies. So this is a celebrity singing. Even international celebrities are banking on low-hanging fruits. Thank you. And with this note, I would invite everyone to AIOC next year at Kolkata. Thank you so much.
Thank you very much. A lot of you will be surprised that from 5,000 feet, she has jumped off a plane also. 14,000. So I will not be able to do that. And you truly need to be in this LDP program. But wonderful presentation. And now I'd like to invite Dr. Vidya Bhushan Kumar, who will be speaking against the motion on eyeing the low-hanging fruit in ophthalmology is enough to rake more mullahs. No.
Good afternoon, everyone, and thank you for giving me opportunity, sir and ma'am. My concept of low-hanging fruit is entirely different from what previous speaker told. So just I am going to. So low-hanging fruits, just grab it is a trap. We should say no. Why? What is the meaning of low-hanging fruits in ophthalmology? Is like low-hanging fruits refer to the easy to reach fruits on the lower branch of the fruits. In ophthalmology, low-hanging fruits means earn money without any risk, like join some hospital established by some other one and do the 9 to 5 job. No innovative idea, no interest to learn new technology, no financial risk. So doing the basic cataract cases like that only, and you should not do anything, any risky things. What we know about our ophthalmology during MBBS is a cool branch which is with no emergency work and lots of ton of money is coming. After postgraduate, it's a branch where settlement is very difficult and the resources intensive unless you are related to an eye surgeon. So the various aspects to make the ophthalmology cool is not depends on the on ophthalmology, but it's on the ophthalmologist and his attitude. What he or she want to become, comprehensive community ophthalmologist and settle attached to someone government hospital where less responsibility and risk, but can earn handsome money for his basic requirement for the family. want to become silent in ophthalmology and earn more money and make the pathway to other forthcoming generation also? If yes, then take the risk and make a habit to start investment on yourself by means to learn new technology, new surgery day by day. What you learn from previous, you should not rely on only cataract and glaucoma, only cataract surgery basic. You have to go for the glaucoma, refractive, vitreoretina. You want to learn all when cataract, be doing routine SICS, phaco, we can go to the flash also. And for ophthalmology practice, we have to purchase new instrument and your own hospital and own clinic, not for the others, so that future it will be better for you. As we know, India is at a crossroad of development, probably still a work in progress. We are being challenged in providing basic healthcare services to mass, but on the other hand, we are emerging as an economic superpower. So there are potential for well-trained ophthalmologists who is independent, confident, and ready to take the risk, not focus on low-hanging fruits like cataract surgeon, a comprehensive ophthalmology, to attach some other eye hospital, to take risk and start your own setup and grow up to infinite. So lesson of the day is your choice only. You want to low-hanging fruits, you want to go up and many fruits. Thank you.
Wonderful presentation. Dr. Rajshekar, your thoughts on this?
No, actually, this low-hanging and high-hanging fruits, is in the management terminology. It's not that you go only for this or only for that.
Yes.
Yes.
So low-hanging fruits, many people, while trying to go for the high-hanging fruits, they forget the low-hanging fruits.
Yes, sir.
So that is where the terminology comes, and hence both are important for our growth. And I thought she will show lower than the cataracts, but she stopped at cataract. See, preventive eye care is lowest hanging fruit, because the moment you keep educating, everybody who doesn't have cataract also is your patient. So preventive ophthalmology or spectacles. No, refraction you wrote. Refractive surgery, I thought, no? Refraction, yeah. So such low-hanging fruits, we have to be more innovative so
Yes,
that we get more.
Thank you, sir.
Thank you, thank you.
Okay. Thank you very much. Can we have Dr. Sumit Lahane here? Go on to next. Dr. Rishikesh Mai, please. Dr. Rishikesh Mai will be speaking on digital marketing on social media by an ophthalmologist is unethical.
Good afternoon and thank you for the opportunity. I'll be defending the statement that digital marketing on social media by ophthalmologists is unethical. Digital marketing is basically, there are a lot of complex words here, but I'll just mention that it's an online platform to promote your products and services. It includes something called search engine optimization, website formation, creating content and things like that. But basically we are restricting in this debate about social media marketing. Now for healthcare professionals like us, it helps in increasing the visibility and also reaching out to the patient. Not only that, the patient also comes to know that such a specialist is there in the town. So he might take your opinion. Sounds good, but there are certain flaws in that. The problem is selling a product is a different issue. Selling a skill, which we are doing, is a different issue, especially on social media marketing, especially on social media. A famous, I think he's from Hong Kong. He mentioned that showing off is a fool's idea of glory. There are four concerns which I have when it comes to marketing social media. One is the privacy concerns. The doctor-patient relationship is purely based upon faith and confidentiality. No patient will like his pre-op and post-op squint surgeries or post-OSIS surgery images to be placed on a social media platform, and that is where the trust is lost. The second part is reputation damage. If a patient can give good feedback about the doctor, he can also give a bad feedback about the doctor, which will definitely hamper your practice. So the third part is legal issues. The Medical Council of India has, according to them, advertisement or guaranteed treatment by a doctor is not allowed. Also, it helps in breaching the professional standards. While you are, there is very high chance that the social media might breach the professional standards. And it's okay that I get a gown or I order a shirt on Amazon and it turns out to be faulty. But it's not okay that I'm not a VR surgeon, but I proclaim myself to be a VR surgeon and then perform a vitrectomy and botch somebody's eye for the rest of his life. That's not okay. There is also a lot of difference between actual and perceived value. All that glitters is not gold. So patient might have over expectations and dissatisfaction. which will lead to this issue. The problem is that doctors lack the strategic planning and understanding of digital landscape. So they hire somebody, and this somebody, they are not much into doctor-patient relationship. They will promote you beyond your own capability, which will increase the patient's expectations from you. But there are still a group of patients who feel that great doctors have waiting lists, not informative commercials. They still feel that maybe the doctor is in need of patients, hence he is advertising. And word of mouth publicity can still work in many of these cases. So stop selling and start marketing. Stop selling and start helping. So when it comes to digital marketing by ophthalmologists on social media is unethical, my answer is yes. Thank you.
Thank you very much. Thank you very much. That's a very hot, debatable topic, and Dr. Rajshekhar will do justice to it.
Thanks, Rishikesh. You almost gave it away. Stop selling and start marketing. Thank you. So, see, we come from that old mindset. Our generation is one where we still think we are the doctors, noble profession, this, that, and all that. Word of mouth and slow organic growth, ethical, unethical, and all that. Ethicality is when a patient is sitting in front of you and what you do to them. You do the right thing in their best interest, tell the truth, be trustworthy, and those are the things which are ethical. But your presence, telling your services, your credibilities, what you stand for to the public is not unethical at all. You can tell. Word of mouth was the way the social system was working those days. Today, I have a friend who wishes his wife on Facebook, happy birthday. And she says, thank you on Facebook. We all keep wondering, what is this family doing? Then the son says, thumbs up. See, this has become a new way of word of mouth. So when we are living in that world, it is definitely necessary and essential. Essential, I am using the word essential, that you make your presence felt on social media. It is not unethical at all. Yes, you said it right. When you are not a VR surgeon, saying you are a VR surgeon is unethical. It's unethical even if you tell in somebody's mouth. It's like, not necessary that you have to tell in social media. Tell the right things. There's nothing wrong. Even the government allows telling your services, telling about yourself is perfectly fine. And social media is good. And in city, people browse. In our own family, in your own family, to go to a restaurant, people browse. They see the ratings. In LinkedIn, in TripAdvisor, they ask. So many people, and it has brought in a lot of accountability also. And you said good things and bad things both can come up. Yes, it's a double-edged sword. So you become more accountable, and you have to manage your social media. And I come from Bangalore. It's extremely essential for us to monitor social media on day-to-day basis, because you don't even know what somebody writes about you. And some negative comments do come, but how you answer it itself becomes a good positive point. Some people say these people charge 800 rupees, exorbitant, this, that, and all that. The answer that you put will give replay in such a way that other fellow feels for 800 rupees they are getting value worth 5,000 rupees. You can use it that way, and you can't go out of that. Trust, reputation, and legal issues, you said. There won't be any legal issues. If there are good reviews about you, that can come handy for your court cases also. But regarding the trust people, it's a mass psychology. If many people have said yes to your services, the other fellow who is totally new also feels that your services are good. So not being on social media is a great disadvantage. And that is where these aggregators, so-called aggregators, are coming in. They are nothing but social media. If you are already there, if Rishikesh, I can type and get you on social media, why will I go to some aggregator and reach out to you? Because you are not reachable on social media, I go to somebody else. So, and hence, as ophthalmologists, we are all tech savvy. Let us devote a little bit of time to ourselves. Unfortunately, these days, the digital media people are little expensive. So if you go to hire some agency, they charge anywhere from 40,000, 50,000. And for an institution, they charge more than ₹1 lakh per month. If you have somebody tech savvy and digital media savvy, you can hire a friend or somebody, and you can manage yourself. It's essential. I feel it's not unethical. In fact, it is essential. Within the law permits, it's possible. Thank you.
Thank you so much. So this was such a hot topic. With the raise of hands, we'll say, how many in the house think digital marketing in these days is a must? Okay,
Even
Dr. Rajshekhar, you win. Okay.
Actually, even I have my own website. I have my Facebook page. This was only for
I was
today.
just going to ask you that.
One more point.
Please go ahead.
So, in this current environment of social media, we also all keep expressing to ourselves that there's this person who's doing quackery, someone is suggesting some eye wash with some herbs and all of that. But the point is that if we don't have our own digital media, who is going to debunk the myths in ophthalmology? So, we should also take it, in addition to, of course, our presence, should also take it as our responsibility to disperse medical misinformation when it is our speciality.
And whenever we are going to the camps and other things, we can set a standard through that social media that what should be done in that camp and what others are doing.
Dr. Pranish Ravi, please come for your next presentation. Google review is a weapon in the hands of a frustrated patient. Yes. Dr. Pranish Ravi.
The counter flag bearer is stuck up in thing under the apple tree, so possibly he'll make it. Hopefully. So, thanks to LDP for the opportunity. So, this is my talk for today, where Google review can be harmful in the hands of a frustrated patient, and I'm siding towards yes. So the importance of online reviews is it improves the trust and credibility. It increases the patient acquisition because patient sees they see your reviews and they create a plethora of ideas as to how the hospital is going to be, how we are going to treat them, and also it also helps get a feedback, and also it acts as a nidus for you to improve on what you already have. So now here comes the bugger. A frustrated patient is somebody who is completely unsatisfied with what you've done, and look, they are not happy with the treatment that they've got. So hands down in India, if you see a frustrated patient, they're going to give only 1-star reviews, and their rant is going to be essays. They'll at least write 3 to 5 lines of whatever they felt, and they'll just explore it to expand it to such a level that like as if something really bad we have done to them. So this is the Google review of my center. I personally make sure that every day I get 5 reviews, and that is the only way to counter this. Because the more positive reviews you get, that's how you have a higher score. And one-star review can bring your review score down to a great extent. So these are all examples of the 1-star reviews that I've got. I just got only 2 1-star reviews in the span of almost 2 years. So this has definitely affected me, and my chairman is he's very lethal when it comes to negative reviews. He makes sure that I don't have any negative reviews. These are only 3 negative 1-star and 2-star negative reviews I have. So how I counter them is, this is definitely detrimental. You go to the Google review page. When you click on, it will usually open the most relevant page. So it will show you few positive reviews and few negative reviews also. And the most negative ones stay for a longer time. They're like stinch. They stay there for some time, and it doesn't go. And people, when they open your review platform, they see it right away. Okay, this doctor is like this. Okay, I should be aware. The most positive review gets hidden off. So how to counter this is, you understand, you call the patient and you ask them what the problem is, and if you're able to, you request them to change this rating star, and you tell that you'll be addressed and you'll be treated properly the next time, and you write a detailed response saying that, so sorry, we are so and such a thing has happened, because not all days are going to be happy days. Some days you might have OP of 60, or some days even 80 you might have. So single doctor, you cannot see that many patients in a stipulated term. Some people will not like more share time, and for some complicated patients you need to take more, they take more space. So this kind of response will kind of negate, and also you can call up and ask them to change the reviews. So from my experience, when working as a center manager, I have felt that Google reviews do matter, and this is how to mitigate it. Thank you for the opportunity.
Thank you so much. Now I'd like to call your opponent, Dr. Prasanna Venkatesh Ramesh is here. Okay, so can we have Dr. Sumit Lahane? Okay, please. Dr. Sumita Mulani will be speaking on monetary incentive is the only motivation for all the workforce in the hospital. No.
ये नहीं है, अगला वाला समीता. नीचे लाइन. हाँ.
Dr. Prashant is here. Dr. Prashant, Dr. Harshit Vaidya. Okay. Dr. Abhishek Onkar. Okay. Dr. Shamik Praful. Shamik Praful is not here.
You want to start first?
Dharmesh Kar. Okay. And Anant. Anant is here. Dr. Sumit Lahane has come. ठीक है, after her.
So, good afternoon, everyone. This is my disclaimer before I start my presentation. So, this presentation is intended to present my point using comedy and real data only. Any resemblance is not my problem. And the exception is my dog, who you'll meet at the end of the video. So, assuming that I was supposed to go after my esteemed opponent, I wanted to matter is that money is not the only influencing factor for job satisfaction and profitability. There are many factors that basically contribute to a happy staff, happy doctors, and for success of your center. And these are some of them. And a lot of them include the working and the living conditions, the management, the environment, and the respect that you give your staff and your doctors in the hospital. So there's a study that talks about the incentives for better performance in healthcare, and specifically in this one, it talks about the fact that monetary incentive is great, but there are many other incentives that can be given to your staff and to your doctors that also go a long way. Forbes also came up with this article that spoke about the deadly consequences of financial incentives in healthcare, where they took two units of healthcare. One is the UK system and one is the American insurance system. And both of them showed that actually mortality increased in patients, and there were many other factors which we'll talk about. Of course, do we really need to stress our staff out more? Is not the medical and paramedical community already stressed out? Yeah, great, you'll give them money so they can buy themselves expensive pizzas and eat themselves to death. Great, well done. Also, it increases politics and toxicity in the work environment. So one of the biggest things about incentive is how do you decide who gets what incentive? Is it just the upper level of the management that's getting it? Is it just the surgeons, or is it just the doctors? And then if you pay the counselors more, but your receptionist who's working the same hours in the morning, do you give her the same? Or how do you divide it? And will you not create toxicity and positive, negative impact in the work environment? For sure. This will create long-term dissatisfaction amongst your staff, and we are seeing it. We have that typical corporate structure in a city like Pune, where I live, and we receive on a daily basis multiple resumes from all levels of staff, doctors, surgeons, as well as counselors and receptionists who are coming in. And one of the most common things that they say is that we're not being given fair incentive compared to the hours that we are, and other people or this person or that person in that same organization is getting more incentive or more cut or more piece of the cake than they are. Another Harvard Business Review article shows that punishment and rewards are actually two sides of the same coin, and they don't give you a lasting commitment. Along with that, it also blurs the lines of ethics, and you'll have a lot of your staff doing things so that they get more of the cut or more incentive. And of course, empathy always goes out of the window because your staff is trying to hurry up and rush through the patients, and they're not empathetic enough, and that's where, Pranish, you get your terrible Google reviews as well. And of course, it does increase the pay inequality because women at the end of the day do have a house to run, do have the rotis to make, and do have to have the children to take care of. So do we want to increase the gap in the pay structure in India, which is already a big issue, where Priyanka Chopra and Alia Bhatt are talking about it right now on their social media? And my last point and my final point is there is no going back. Ek baar sher ke muh mein khoon lag gaya. And once you have decided to go the incentivized way, then there's no coming back from that. And to just prove that, this is my dog Obi, who I spoke about earlier, and I'm dangling a carrot, which is what the business people call incentive, dangling a carrot. And I taught him how to play dead in Obi during COVID. Bang, bang. I taught him how to play dead by doing bang bang. And look at him, he has an Oscar-worthy performance. He has a great life, goes traveling, eats French diet food. But being the most loyal animal to man, the moment you don't give him the carrot, bang, bang, he's like, sorry, bro, not happening. So just to
That was a
conclude,
nice video.
at the end of the day, your ultimate incentive should be pay your staff enough, pay your doctors enough, give them enough respect in your institute or your hospital or your clinic, and create a hospitable environment, and also train them well enough so that they are qualified for a good enough salary to start with. So you don't need to incentivize, you just pay them enough and they will be happy. You will not have a single staff member leave you for years.
Thank you very much. Thank you for the wonderful presentation. Sumit, this is going to be hard for you. Dr. Sumit Lahane will be speaking on monetary incentive is the only motivation for all the workforce. Yes.
Thank you, Chitra ma'am, and the LDP session AIOS for this opportunity. So Sangeeta ma'am has spoken about the other incentives, and again, to start with, I do completely agree with her, even if this is a debate, but I would like to put my point like this. Incentive planning, basically there are multiple options available, from money to the consultations to the other incentives, achievement, gift voucher, the staff of the month award, and everything. But my only question is, we are talking about the hospital staff here, and it's always better to understand what do they think, and you need to put your foot in their shoes, that what are their requirements. It's not you can consider yourself as an employer and then give them incentives. It should be other way around. So they have a completely different set of a problem than what we understand. So on the left side, I have shown a picture where they are traveling, walking, and they are trying to save the bits and pieces of their money to reach to the station or reach to the platform by walking. And here the employer generally goes through the AC cab or the AC car. So the whole set of a problem in the employer and employee is completely different. We need to understand their problem. We can tell them, we can give them job satisfaction every day. At the end of the day, I can call all my staff and say, very good work you did today. We saw 10 patient, 20 patient, 50 patient, whatever number it is. But that is not going to solve their problem. They have their own set of problems where they have to pay school fees, they have to put their children to the tuition, they have their own EMIs, they have to buy home, they have home loans and everything. Just giving mere job satisfaction, putting their picture on the wall saying that this is the employee of the month is not going to sort out their problem. Somewhere down the line, we need to understand that the salary is the primary aim for which they are working. And try and understand this picture very carefully. All of us are stuck because of our responsibilities. Consider all of us sitting here. If our hospital is not running, or if the clinic is not running properly, all these people sitting here, will you be able to attend AIOS, leave your clinic shut and then be here? No. Cause your problems are sorted, cause money and the bank balance is good enough, and you know that 3 and 4 days holidays can be taken. That's why all of us are sitting here. Your staff cannot do that. So that can be solved only when they have a good money balance in their banks. And if you want to give an incentive, of course, there are studies done and they have shown that job satisfaction and everything is important. But again, remuneration is most important criteria that they have found. You want to give them incentives, the money is not the option, then give them investment plan, cut their salary, tell them that this is how you need to invest, and educate them about the financial freedom, instead of, if you don't want to give them a money straight away, that will they need to be educated that there are policies, there are schemes available which will be helpful for them in the long term. Giving them this kind of education is also incentive, is also a money, and that will help them in the long term. This type of incentive is very important, just other than doing anything else or just job satisfactions. So we need to understand that these things do work, but at the end, paisa bolta hai, and all of us need to understand that. Thank you all.
Thank you. For paucity of time, we'll quickly move on to the next speaker. Dr. Prasanna Venkatesh Ramesh, did he come back? Not yet. Dr. Prashant Girish.
Can I have one quick question to the two
Please,
presenters here
please.
as an expert panel?
We would like to welcome Dr. Feroz,
Hi to everyone.
Member Scientific Committee of All India Ophthalmic Society. She is on our expert panel. Dr. Feroz, please.
Yeah, so both of you. So what is one thing, I know you are young administrators as well, being excellent clinicians and surgeons, one thing that you consider is so very important as far as your staff is concerned in your practice, just one thing. Sumit. No big sentences. Yeah. What is, no, not expect. One thing which is more important in building a team with your staff. We spoke about the monetary thing here. We talk about, yeah, the entire team. What would you think is the most important thing that will keep you together to have a happy environment or a, productive environment in your
Sumit,
practice?
mic.
So it's protection. Is it that trust and protection? Trust and protection from Sumit. What about
For me, it's communication.
communication?
So I like to speak to my staff once a month and
Yeah.
not together in a group, one on one. I like ma'am earlier spoke about water cooler conversations. I think that that's so important because sometimes you realize that when you just have a casual conversation, not as a boss, but just as someone who's in the same place,
Yeah.
they will tell you certain things, like they will communicate certain things that maybe they feel they are not getting or they are not achieving because they have been stuck at a particular level.
The
And you can a
stagnancy.
lot of times move around people in the organization to optimize not only the outcomes for your own organization but also for them. So if they are able to take up management roles or they are able to do more and in turn be paid a salary, or like I said, that's the basic. You pay them market rates. You don't need to look at incentivized things if you give them satisfaction in every other way.
Okay, can we move to the next?
Thank you.
Dr. Prashant Girish is here. Dr. Prashant Girish. Dr. Harshit Vaidya. Prashant Girish is not here. Harshit Vaidya will be speaking on having an individual professional indemnity insurance is a must even for ophthalmologists working in charitable and government institutions.
So good evening, everyone. Thank you, the team ARC, for calling us here. Well, I think the topic is such that it's probably an untenable situation for me, but my opponent doesn't seem to be here, so it seemed like a victory anyways. But having said that, it's a challenging debate topic, but still there were some points which I came across and I thought that it'll be good to discuss as well. Current situation of our doctors, right? So we are following the trend as the West is following. We're getting more scared to treat our patients. This is more so if you see in private practice, we'll see that we'll order tests, we'll order investigations, we'll do everything to ensure that our, we are safe on our end. Sometimes we'll order an MRI for an optic disc, which we may think that, okay, we may get away with it, but to be safe, we may order a test, right? So we are more protected and more scared. But maybe in a government setup, doctors do not need this because the patient profile is different. So here, this is a typical scenario, right? A government setup, the patients come there only to get treated. They don't have expectations of having a fancy, unit, having to be spoken to well. Although that's a necessity, that's a requirement that we should be fulfilling to each of our patients. But patients primarily come to a government setup for getting a simple treatment. In this scenario, doctors have to just fulfill their duty of treating the patients well. Of course, if we can speak to the patient 1 minute extra, that communication the doctor was just talking about. Even so, if we can extend it to our government practice. Now, I have just joined a government practice recently as an honorary consultant in Mumbai. And, seeing a private practice and joining a government, I can see a total difference. I joined a government after 14 years of education and everything, and it feels like a totally different ball game altogether. We are more concerned about talking to patients in a private setup, but in government, the lack of communication is where, if at all, we land up getting into litigation, could be because of that. So that's a major difference between a government setup and a private setup. Another point which I found, unfortunately, I don't have any studies to validate like how everybody else had in their previous discussions, but to just a Google search and just talking to a couple of lawyers, there was no legal requirement of having a professional indemnity for a government practitioner or a government doctor. As opposed to if you go to even if a corporate setup or all of us are doing, whoever does freelancing, they will be asking for a professional indemnity just to be safe. So in a government setup, that is not a requirement. When I submitted my documents, it wasn't a requirement. And I spoke to the HOD of the hospital as well and the dean, even they didn't have to submit. So by law, it is not even necessary. So another important factor, right? So how do government doctors view as opposed to private? Unfortunately, that's the situation. If you see government doctors, they are salaries are way less compared to what private doctors earn. So adding a professional indemnity where patient profile is such where you're taking chances on a 1 in a million, that would be asking for too much. So it's like taking comparing a government and a private setup, right? So would we take a CMC and a AMC for a Centurion, but would we do the same for like a lower end model of an Appa or something, right? So if you can compare the two, this is a situation which I would compare it with. So to conclude, it's a low resource setting. The patients are unaffording. There is no legal binding. The lower salary of the government doctors and unnecessary paranoia. I think we can do away with a professional indemnity and a government setup. Thank you.
Thank you very much. We'll all agree with you. Dr. Harshit Vaidya is there?
Sir, I just got up.
Oh, sorry. Dr. Prashant. Prashant is not here. So Dr. Abhishek Onkar. In the meanwhile, Dr. Feroz, you would like to comment on the previous presentation?
I totally agree with them, and they are, so communication is definitely very, very important. I think taking the staff along as a family, it's so very important. Even identifying personal bonding is so very important, and that's when you get that, honesty and loyalty, obviously, so, and choosing the right team is so very important. So I think, taking care of the staff really, really matters. Ultimately, they are the ones, who is in the front. I mean,
absolutely.
Just right there in front, facing the patient. And I think, that's how.
Dr. Abhishek, please. Dr. Abhishek will be speaking on partnering with medical aggregators is a betrayal to your own fraternity. Yes.
Good afternoon to all. Thank you, LDP, for providing me this opportunity. So I will start with the patient's perspective regarding these medical aggregators. So if you can see the bottom line of it, even the patient is aware that they are just after your TPAs or the money. It's nothing about patient care at all. So as already our previous speakers have spoken about, if we are dealing into the core competencies of our speciality, that is what matters. The patient care is what actually matters. And this lack of care, which actually the patients even can perceive, is what is betrayal, not only for the patient, but for our fraternity at large. So what these medical aggregators actually preach is this about simplifying surgical journeys, easy access, and quality healthcare. But what in practice is actually totally downhill. And each of the 3 points highlighted out there actually are towards the betrayal towards our own fraternity. So misleading and biased on information, prioritizing one's practice over others. That is what medical aggregators can largely do. And like our previous speakers already mentioned about Google reviews and all that, we already know that some reviews can actually be bought, and search engine optimization is something that they do to put you on the top. So it's all about spending the money, and definitely abridging that legality and ethical issues is a betrayal to our fraternity, right? The breach of data privacy, unauthorized data access, and that too for the analysis. So not only the patient data is at stake, but that is actually being utilized to channel the patient towards whosoever pays the aggregators. And lack of regulation. So this is one point that is actually a very pertinent one. So yes, I will come to that again. So reduced autonomy. So you are not actually in control of your patients with EHRs in play, the medical aggregators in play. Reduce income because actually you have to pay a lot to the aggregators. So some part of your income goes there, and actually it's a burn for the patient is who bears the brunt of all this, right? And like we come to the medical aggregators who actually had to face a lot of trouble in the Occidental countries, and where they actually have to undergo a lot of stringent acts like the Stark law and the anti-kickback systems. But unfortunately, in India, there's a lack of those regulations. Is still in its infancy. So that is why they are thriving. That is why they are being propelled, and that is why some of our fraternity tends to join it so that their business gets augmented. So my question remains, like, just for the sake of money, is it okay to forego the ethics and the morality and the legality as well? So just to end my discussion, and for the fraternity to decide whether whom are we actually partnering with. So the right one is the wand of caduceus. If you all know, that is actually is the more common symbol. Everyone recognizes as a medical symbol, but actually that symbolizes what is known as trade and thievery, the wand of Codicius. And the original is the word of Asclepius, whose daughters were Hygia and Panacea, which actually symbolizes medicine. So, but we always tend to forget it in the favor of what is more in vogue. So, I will rest my discussion with that. What and the fraternity needs to decide what is.
Thank you very much. Thank you. We are extremely low on time, so we'll move on to the next speaker, Dr. Dr. Prasanna Venkatesh Ramesh is here. Yes. Because we have to start the PG thesis competition, so he'll be speaking on Google review is a weapon in the hands of a frustrated patient. No.
So, can I have the mouse? Yeah. So as usual, my friend here, 15 years back, this is me and my friend. We fought last time in a undergraduate competition, and we are going to fight again today. Pranesh Ravi spoke in favor of yes. I'm going to speak in favor of no. Why it's not going to be? Can you just play? Yeah.
Pranesh has already spoken.
Yeah, playing the video, sir. It's a 2-minute video only, just a short video. So once again, Pranesh has fought leaving me alone, so I'll have to come back and fight with these 10 points. So, are you playing the video? Yeah, it's a 2-minute video only, yeah. So I'm going to say why Google review is not a weapon. So it's a no. And I'm Dr. Prasanna Venkatesh, and the video is not playing. Yeah, fine. Now it's fine. So point 1, improving healthcare outcomes. So when we get a negative review, we can focus on improving the performance of the staff and the infrastructure. It is actually a negative feedback, but we can actually improve the quality of care of all. So that's my point 1, because negative reviews of a frustrated patient will actually allow us to improve the healthcare and finally improve the hospital's infrastructure overall. And most of the negative reviews are actually because of other non-medical issues rather than the medical issues. If you go and see waiting time with the doctor, privacy, administrative issues, and additional amenities like family friend fooding. And also if you see there is an increase in the total count and history of an institution. If you have only negative reviews in between positive reviews, that will give you a credentiality. You can't have just only positive reviews. That's point 3. Point 4 is loss of trust in the online platform. Patients today don't see only the negative reviews, they also see the positive reviews as well, or they take it as a whole manipulation itself. It is losing its credentiality today. The trust of the patient is lost when it comes to Google reviews. Point 5, also there is an option to delete the negative reviews. If you want to convince the patient in a personal level, just tweet to the patient or delete the review and then take their phone number and then talk to them and make sure you understand that, okay, this is what happened, this is what we can help you solve it. And the credentiality of the Google review is also questionable. You can see literature saying that 50% of the health systems and 65% of physicians have no reviews, and there is no proper validation, my dear friends. How do you rate a review? There is no proper validation. Anybody can just A, B, and C, just go and put a review. So, but reacting is very important. Apologize, thank the reviewer, additional support, approach team should be there to connect with the patient, call the patient, listen patiently, and then finally change your practice. It's a not a no. It definitely helps you in developing your practice. Thank you.
Thank you. We'll quickly move on to the next speaker. Dr. Dharmesh Kar is here. Dr. Dharmesh Kar will be speaking on investing in mutual funds is the best way for a busy clinician. Yes. We have the next PG thesis competition for which we would like to welcome Dr. Dada, Dr. Quresh Maskati, sir.
Yeah, good evening. Thank you, ARC and Chaitra Madam, for the opportunity. So, mutual fund investment is best for the busy clinician.
And Dr. Vijaya, ma'am.
Yes, and yeah. So, financial is a none, and mutual fund investment is always subject to the market risk as it's being marketed. So why mutual fund? Everyone wants to go for it because for the passive income and wealth creation, other source of income is required than the medical practice. It's a time-saving thing. No worry for the day-to-day volatility of the market. Quality time for your family and your hobbies you can have. And the aim is to achieve the financial freedom. Now, what is a mutual fund? Everyone knows there's a common pool of fund contributed by investors and invested in accordance to the objectives. SEBIs and other bodies come into the picture. They make a trust and every investor can be the part of it. As a classification of the mutual funds, but as an investment, everyone knows it's open-ended, close-ended, interval funds, debt or equity, or you want to put in the hybrid one, or a passive or an active fund. and all the details we know, but the debt funds, or you put a high risk in the equity fund, or you want in a middle like mixed hybrid or equity funds, how to put, or the passive fund which is just with the market on, depends on the market index, or the active fund which is goes on the sector, and as per the sector goes, there is a categorization. How to invest is by the physical thing, very easy on a mobile app. You can go online mode and we can invest. There are the procedures we can done by the lump sum investment or the SIPs. So one time investment, or every month we can start an investment as soon as we start our first salary. There is a direct mutual fund, there's nobody is involved in between, or we can have a regular mutual fund where we can go to the agents or the intermediary body in between. There's a growth options, dividend or dividend reinvestment options. So different payout options are also available. There is a SEI or SID, that is the statement of additional information, or you can get the scheme information document from the mutual funds. That the risk matter from the low, moderate to high, and very high risk. So as per our risk appetite, we can take the which mutual fund and where to invest the money. Our aim is to achieve the financial freedom. Everyone just don't want to sit in the clinic from 9 to 5 or 9 to 8 and work. So you want to go for a trekking, you want to enjoy. So everyone wants from shift from active to passive income, so that money works for you. Hands off the income is a must. There is no schedule and a freedom. More risk, big reward, cash flow. There are many ways of passive incomes. More time for yourself, flexibility and payoff. So always you have a more freedom, quality time for yourself you can get, and you can time for your hobbies. So there's just a small video, and we have always doctors being busy and have an excuse ready for the investment. So start your investment from today itself. Don't be investor. Sorry. The way to get started is quit talking and begin doing, as Walt Disney said. So it is the best investment tool for all. Thank you. Thank you.
Thank you very much. And we'll have the last speaker for today, Dr. Anant, who will be speaking against the motion investing in mutual funds is the best way for busy clinicians. No.
So, good evening, ARC team, and I would like to thank Chitra for giving this opportunity. Let me, in a light-minded way, ask how many doctors here feel that you are very busy in your practice? Please raise your hands. Busy in your practice, justified. Yes. Do you invest in mutual funds?
Everybody is busy, nobody is raising their hands.
Yeah. So the previous speaker was telling that mutual fund gives a financial freedom. The topic is investing in mutual fund is best for busy clinicians. I'm just talking as a busy clinician, not as a normal doctor. So I'm giving some personal touch to this topic. Let's see. This is how in mutual funds works. He has given a lot of theory about it. We are investing your hard-earned money. They put in the market. What does Google say about a busy doctor? A doctor who doesn't send a potential patient away. What I personally feel is you feel blessed and cursed at some moments in your life once in a while. That is busy doctor. One patient was telling me, sir, you are just a man with a heart. This is what busy doctor is. Why people do invest in mutual funds? Because they want financial freedom. In mutual funds, there is a professional guy who manages this. You can diversify your amounts, you can afford from small amount to big amount, and you can withdraw the cash whenever you want. But look to the people who are investing in mutual funds. They may be good, but who are investing? People who have got fixed salaries, their income are below 20-25 category. Busy practitioners means you understand they are on the 5th or the 6th line. So they are very, very, very minimal investing in this. And a busy doctor means we have time for everything. I'm taking so much risk, earning so much of money. Why should I believe on one guy whom I don't know to invest my money? That's important. And what's the maximum result returns we're getting? 12 to 18%. Disasters of mutual funds is known to everyone. We are already become busy just by looking to so many disasters in fake wound refractive surgery, and we have made money out of this only. These disasters we never want. This is my personal touch. This is how a busy doctor life goes. See this schedule. Once I am busy, the patients are getting multiplied every day by day. Even in spite of it, my activity into academics, I am a VIP in my city to inaugurate so many things. My patients are replicating each and every moment. So huge amount of money flow is coming back to us. Busy doctor has got it. He's a triad of good skill, knowledgeable guy. He's updating his technology and a good communication skills. So whenever I get this, let me give you a small example. We were back in 2009 when we bought our femto LASIK machine for 1.7 crore. I could earn back that money within just 1 year by doing 1,000 cases. So you put in vertical growth of your hospital, you expand the hospital, you put in real estate, become sleeping partners for hospital industry or whatever, and buy some gold which is required for your kids. And be aware of the trends going on. And without mutual funds, this is how I've fulfilled my dreams in last 5 years. And at the last, thank you.
Thank you so much, Dr. Anand. That was a wonderful presentation. That brings us to the end of this
I'll just
session.
make a comment here
Please
for
go
the
ahead.
entire audience. So, yeah,
बोलें,
just 30 seconds. What is so very important for all of us is financial intelligence. And something which is very important is called MSI, multiple source of income. So that keeps us happy. And definitely money is
Important.
happiness. Yeah, it is. Thanks.
Happiness.